bear the brunt of it. And so from that, I hope we see a lot more collaboration between public health and healthcare. And we can talk about some specific ways why I think that's both important and necessary and will be helpful. We also saw, in my mind, all sorts of interesting innovations over the last 3 years. And we've talked about some of these, Mark, but things like test to treat. Test to treat is this very simple idea that really started for COVID. It was a way to get people access to treatments who don't have access to healthcare. But in my mind, this is something that should stay with us forever. And we should go well beyond COVID. There is no reason somebody with a respiratory illness should have to go to the doctor's office or should have to go to the emergency room to get that diagnosed and treated. Like, that should be happening at home. It should be happening in other places. So there are these innovations. Obviously, telehealth has been extraordinary in the last few years, and we're going to keep some of those going. So there just have been a series of innovations that I think we have to build on. And the last point here, in much of the conversation over the last year in the policy world, as we started talking about unwinding the public health emergency, a lot of people said, the emergency's got to end. We got to go back to 2019. I was like, no, we're not going back to 2019. Like, 2019 need not be the glorious year that we're always trying to go back to. Like, 2019 was, had some problems. And what we should do is think about, like, what does 2023 look like post-emergency? What does 2024 need to look like? And how do we build on the lessons of the last 3 years? And that will require really close collaboration between both public health and medicine.
Can I ask one follow-up on that point about, you mentioned test to treat starting out as something that occurred, I think you said outside of healthcare, but yet this is something, I mean, if there's something that healthcare would be expected to do, it's help with diagnostic tests for people who are at risk, and then do the follow-up to make sure they get effective treatment and prevent complications of their conditions and further downstream health problems. Can you say a little bit more about, I mean, it seems like that should be like front and center in healthcare, and a great point of alignment with public health goals.
Exactly. So the reason I described it as outside of healthcare is it was in some ways designed to deal with people who did not have traditional healthcare, right? So when treatments became widely available and testing was widely available, the administration realized there are people who don't have access to healthcare, don't have regular source of primary care. We need to make sure those people get access as well. And so it started in places like minute clinics, but quickly moved into vans that go into communities. And in my mind, it's actually a great example of, it's deeply medical, right? It's literally a diagnostic test followed by a therapy. And yet it's deeply public health in the sense that it's population focused. It meets people where they are. It doesn't force people to get into their car and come to their doctor's office. Things like that are great interfaces of public health and medicine. And we just got to do a bunch more of those.
All right, we're going to talk more after your session about how to do that more effectively. I did want to bring up one other topic that I know has been front and center for you, and that's trust in public health, trust in government officials and guidance. As you know, there are different views in the American public about prioritizing things like restrictions on individual liberties, mandates, and things like that have carried over into or related to just different frames of looking at public health issues and population health. While there have been some declines in trust in some areas, if you look at the latest polls, healthcare professionals, your physician, your clinician, your pharmacist, still, your nurse, still are way up there on both parties across the board. Can we build on this kind of trust to help make more progress on population health?
Yeah, absolutely. So first, what I would say is we are obviously in a moment right now where we're just coming off sort of the emergency phase. And I see this time period as a little bit of the sort of the post-acute trauma period where people are angry. There is a desire to sort of, by some people to move on, other people to kind of relitigate the last 3 years. And I think as things cool a bit over the next 6 months here, it will create an opportunity for us to have some more robust conversations about what did we get right, what did we get wrong. Look, nobody has been right on everything in the last 3 years. I was going to say nobody's been wrong on everything. Actually, there are some people who've been wrong on everything, but none of us certainly have been right on everything. And part of the healing process is acknowledging that and moving forward. It's not just healing in the community, it's also about then beginning to build trust. There is no question in my mind that public health has gotten very polarized. The ways to begin to deal with that is by talking to people, and is through dialogue and engagement and talking to people who are not already converts into your worldview. I think there's not enough of that happening in the United States, and that's something that I feel is very, very important. And then to your question around healthcare providers, there is no question they are like central to rebuilding the trust in the healthcare system and public health. They also need training on how to do that. There's a bit of a sense that doctors and nurses can just do this. In a highly kind of polarized, complicated moment, I actually think we need to help train people on how to engage. And I've had pediatrician friends who tell me that like they've had, parents that who've always trusted them on every vaccine and now are turning on them and saying, not only do I not want the COVID vaccine, I don't want any of the vaccines you're offering. And they are truly befuddled about what to do at this moment. We need to help clinicians sort of understand the moment, engage with those parents, and rebuild that trust. I think that's just work that we have to do as a community.
Sounds work, and sounds like, just like your other comments, we are living with COVID, but we're doing it in the context of these broader health challenges. Ashish, thanks for being with us and for tying all these ideas together. It's great to see you, and thank you for your public service.
Thank you.
Thank you. All right, and I'd like to move right from this discussion into some important follow-up on the topics that Ashish brought up by bringing up our first panel. This includes Celine Gounder, who's Senior Fellow and Editor at Large for Public Health at KFF Health News, Farzad Mastashari, Founder and CEO at Aledade, and Ann Zink, Chief Medical Officer at the Alaska Department of Health and President of the Association of State and Territorial Health Officials, and winner of the Duke-Margolis Award for person who came the farthest to be here. We're really glad to see you in 3 dimensions. You heard what Farzad had to say about the challenges facing healthcare, and I'm sorry. You know what? There's some of these MD public health people that you heard what Ashish had to say about the challenges facing healthcare and public health, and so I'm very pleased to have 3 people with me now who have deep experience related to these issues, spanning a spectrum from leadership in public health and healthcare reform to frontline work in emergency and primary care, sometimes at the same time between the 3 of you. So a great group to talk about these next critical challenges for America's health. And I'd like to start, Celine, maybe with you. You've been deeply involved in thinking about and finding ways to address the kinds of challenges that Ashish and I discussed around public health and population health, and maybe how healthcare can do more to help. In your roles as a public health researcher and infectious disease clinician, more recently, major role in public health journalism at KFF Health, CBS, et cetera. What do you see as the challenges, but also the best opportunities for moving forward?
Yeah, ahead of this panel, I was sort of thinking about, is there one biggest challenge? Unfortunately, I think there are a number facing us. One is the federalist system of public health, with much of the authority, much of the boots on the ground, much of the funding at the state and local level, not at the federal level. And when it comes to data and having knowledge in real time as to what's happening on the ground, this has been a major challenge that other countries, frankly, have not had to contend with to this degree. So if you look at the countries that were able to give us much more real-time data about vaccine effectiveness, for example, countries like Israel or the UK, which depend on data that is centralized, like the National Health Service, that makes it much easier to have that kind of real-time data, which in our system, because we have to collect that data from the state and local level up to the CDC, clean up that data, align that data, analyze that data, it's just much more difficult to have in real time. So that's one major challenge. A couple others, the anti-regulatory environment that we're facing right now. So a number of states have now passed laws to limit state and local official health authority in the context of emergencies. Communication has been a major challenge, and I think we need to start thinking of communication as a tool of public health, not just releasing a report or guidance, but really using it as a tool for behavior change. And finally, trust. And this is something that has been, we've had a longer arc of history with a real drop in trust in government, starting during the Johnson and Nixon years, and has continued to drop since then. And so public health is part of that longer arc of history. Greatest opportunity, I think, and this is, I know some of what the conversation will be later today, is the transition from fee-for-service to value-based payments as a way of driving accountable population health, using some of the authorities that CDC does not have, but that CMS, for example, has to corral that data, to collect that data, and then to provide it to others in public health, as well as elsewhere in HHS. So I think those are some of the critical opportunities we have in this moment.
Thanks, Celine. Covered a lot of ground there very concisely, and just would remind people, if you did go to that QR code for this session, Duke-Margolis released a discussion paper today on these topics, the future of public health and accountable population health, highlighting some of the themes that Celine just described. That was co-authored with our Duke team and Mandy Cohen, then previously head of Department of Health and Human Services, now at Aledade. And I wanted to go next to Anne, who, we got to know each other more than I had expected in 2019 as we worked together on some of these same kinds of issues over the last few years. And I have to say, I've been really impressed with the ability of your ability to bring perspective of an emergency physician practicing in Alaska, and sort of, it's not even suburban, right? It's like well outside of Anchorage, right? At the same time as you're leading Alaska public health and playing a critical leadership role in the National Association of State and Territorial Public Health Officers. So, based on your experience with all of this, are there reasons to be optimistic that healthcare and public health reforms together can make more of a difference in improving population health, not just in the emergency response, but more generally?
Yeah, no, absolutely. I mean, I oftentimes say that I'm more nervous about my next shift than the next pandemic. And I think that the ways that we think about healthcare and public health are going to be transformational. I don't think we need a healthcare system and a public health system. We need a health system. And that's going to take both of those together and working together. I think one of the things I told a couple people last night, my journey and story, I never really planned on going to Alaska. I'd been a mountaineering guide up there, ended up practicing emergency medicine up there. But then I quickly saw that you could create change in ways that I had not been able to other places. So if we were having massive deaths from opioids, it took providers, it took patients, it took policymakers, but it also took the public and it took the press. And by working with those 5 different groups, you could radically transform how many people you were saving from opioids, your entire approach to it, how many you were doing in the emergency departments, the policy around that. And I think in resource-constrained environments, there is an opportunity to be able to be innovative. We see this in business all the time, to bring in new partners and to think about healthcare and public health in a different way. So I am incredibly optimistic in the sense that we have been through a hard time and we have seen, and some of those gaps have been really exposed. But I think it's really up to the people in this room today on what we do about that. When you have your next healthcare meeting, did you bring public health to that meeting with you? When public health has that meeting, did you talk about CMS? Did you talk about healthcare with you in that space? And so I think that the ways that we braid those together in our daily operations, I mean, we have plummeting life expectancy with increasing healthcare costs, and we can just continue to silo up and get into our own spaces, but we need to look accountably for all. And we need to think about all patients in this country and how we move forward. But I am excited by the innovation that we see. I think that there's already been some significant changes. I think, postpartum Medicaid coverage would be one small little example, right? Like we saw this during the pandemic, Congress said pass it, and we have seen it kind of sweep across the nation with states taking that on because it made sense. It made sense for patients. And then honestly, from a state perspective, Celine talked about the federalist component. It's really hard at a state level to do a lot. There's a lot of components to it, but it made streamline efficiency from the federal government side so that it was really easy from a state level side to enact. I didn't have to find 10 people and a couple $1 million to do an 1115 waiver and to prove to the federal government that an idea they already had approved would be another good idea to approve in that space. So I think we've got a lot of opportunity and we're seeing acceleration there.
And it's certainly an area where we've seen worsening trends in terms of maternal health outcomes, and one where it is possible to track and see how well these new coverage approaches are working. Well, you talked about bringing together healthcare and public health, bringing them together. Farzad, you've kind of done that in your whole career. Well, you start out your early career, I think in New York City, right? And if I remember right, your work focused on addressing some of the most straightforward medical steps available to reduce cardiovascular risk, things like blood pressure control and cholesterol levels. And and you've gone on from that to work that it was a privilege for me to be a part of, and laying a foundation for a vision of a much stronger primary health care that was accountable for things like these population health improvements. What are your thoughts on putting these two pieces together? It does seem like healthcare is critical to these efforts. As she said, test to treat, that applies to blood pressure and cholesterol as much as COVID. But that there also are critical roles for public and community steps in these efforts.
Yeah, I'm really glad we're having this conversation. The connection, I've spent my whole career, as you said, kind of in between and betwixt healthcare and public health, trying to bring more of a public health, or the way it gets translated often as population health thinking, into healthcare, and also trying to bring a little bit more of an understanding of the frontline clinical experience to public health. I remember I was an epidemic intelligence service officer right in my fellowship in the New York City Health Department, and I saw a case lab report of a communicable disease that I was outraged that we hadn't gotten a case report from the physician who treated the person. And I called him up on the phone, white hot, white hot. And I was like, did you see this patient? Right? Did you report this? And the guy, like stone cold, said to me, are you going to pay me for that? And I was just shocked. Like, what do you like? And I was like, literally what went through my head was, like, I'm going to call the police on him. And like, that is somewhere between that and public health thinking healthcare just doesn't matter, right? Is where public health has been traditionally vis-a-vis healthcare, right? Because for centuries, healthcare didn't matter. Literally, like what saved lives was sanitation, was like, boiling the milk, was cleaning the water, like that. Changing the environment is what mattered large scale in terms of the reductions we saw in deaths. But that has changed, and we now cannot be good stewards of public health without engaging the healthcare system. So I do think we are in, this is the right question, right? The most important thing is working on the most important question. And this is the right question for us to be asking.
So let's talk about answering that question maybe a bit more effectively. So Ashish brought up test to treat, which it's sort of like your experience with a physician. That's like, well, why would your first thought be, well, we've got to focus on outside of the healthcare system for that? Is our healthcare system, you all are experiencing and living it? What is needed in our healthcare system to be the first place you turn for initiatives like that?
Let me just give one example, and I'll turn it over. When I was in New York City, we had a New York City Center of Excellence in Public Health Informatics, and we did this small program where it was a Sentinel program where a federally qualified health center collected respiratory samples throughout New York City. We got a multiplex tested by Ian Lipkin's lab at Columbia, and we were able to see what was going on in the community in terms of a whole range of respiratory conditions. That project was funded for 3 years and gone, right? So having Sentinel sites, and this is one of the things, right, where we were funded, we had a special relationship with CMS. We're getting weekly claims data from CMS as accountable care organizations caring for populations of patients, but CMS never said to us, be tools for public health. During the COVID pandemic, There was never a concept of using the infrastructure we built for value-based care as an example, or to fund sentinel sites to say, let's do systematic collection of data and transparency around that and pay for it for public health purposes. That is, I think, one example of where these two worlds start to come together.
Yeah, and that was the other paper that we released today. We're gonna have Nikki Lurie with us on the next panel, who's thought a lot about data issues at the healthcare public health interface. But Celine, you brought this up as well. Data, without good situational awareness, it's hard to have effective public health response. And there is better data on issues like new cases, opportunities for treatment coming out of healthcare. Would that help solve some of the challenges you raised?
Yeah, so I think with test to treat as one example of what you're talking about, if you think about what are the populations that we're targeting, whether this is for blood pressure control or diabetes or HIV or Hep C, these are some really hard to reach populations, underinsured populations, uninsured populations that the healthcare system has really not catered to, especially under a fee-for-service system. And public health has been something of a Frankenstein of some strategic activities, some things around environmental health, which fall outside the purview of healthcare, and then clinical services. And clinical services typically have been TB, tuberculosis. I think that was a case of TB you were talking about, Farzad, but TB, sexually transmitted infections, immunizations. And we really haven't in public health been able to move away from those clinical services because the healthcare system is not delivering those. But we're frankly not great in certain aspects. Like I'll just give one example, billing. So I used to be in charge of the TB program in New York City, and we were terrible at billing. We left a lot of money on the table, but that requires having the billing infrastructure, the people, the technology to then bill, and that requires investment. And so you're kind of in this chicken and egg situation of you don't have the funding to invest in the system that would allow you to collect the money to deliver the health services. And so you're always in a losing situation.
Yeah, and I think in terms of that investment, I think the infrastructure you're talking about, Farzad, was not just infrastructure for, okay, I'm going to treat this patient right now for this infection, but longitudinal data that would help you know the population in your accountable care organization, so you could anticipate which ones might be having problems, and so you could make sure not only do they get that infection followed up on appropriately, but other health risks that may have contributed to getting an infection in the first place and so forth could be addressed. I know you mentioned a maternal health example the same direction, where we just don't seem to be doing it yet in terms of getting the data together with the accountability. And to Celine's point, many of the people who are at highest risk for these conditions are least connected to healthcare providers and longitudinal systems today. So I know if you've got further thoughts you'd like to add on this topic, Anne, since you helped us bring it up.
No, I really appreciate it. I mean, I think both healthcare and public health like to see themselves as data-driven specialties, but if you don't have the data, it's really hard to be data-driven. You know, during COVID, we put a National Guard in our state lab to enter one test into 3 different health systems to just be able to get the test to us, to be able to get it to the CDC. And so, you know, there's this lot of like, well, we want you to, and why won't you? And I'm like, I literally have people entering into these really broken systems. So I think we have to invest in the infrastructure of public health, healthcare systems. Even when the federal government said you need to send race and ethnicity data, and the healthcare systems were like, cool, we'll turn that on. It was kind of like, I think of a catcher and a mitt, and we were being bounded by baseball bats, and we didn't have the like catching mitts to handle it, right? We were like, never mind, turn it off. Because it essentially broke all of our systems so that we couldn't do even the basic things. So you have to make sure that the public health system of the catching of that data is adequate and has the same standardization, has the workforce, has the same communication. I also think culturally, like I've oftentimes said, like, where's the epi and epic? Like, our epidemiologists should just be able to go over and see de-identified data that's within the healthcare system. I mean, my epidemiologists have no idea what healthcare data looks like. They're like, what do you mean that's out there? And I'm like, there's so much there. Like, you guys would be floored, but they just don't even know what they don't know. And I think finding ways to be able to build that, I think we strategically need to go through, and I think, you know, Duke has done a great job of kind of listing those out and creating really strategic priorities on how to make sure that data is there. Again, a lot of my experience comes from emergency care. And, you know, in the 1980s, we said it's not okay to show up in an emergency department and not get stabilized. And so EMTALA came through, and now as a condition of Medicaid, you stabilize. I really feel like coming out of this pandemic, it should not be okay to be accepting large federal dollars and not being doing basic data sharing and information sharing for public health. I think we have to come to that point.
So Impala for surveillance and test to treat. Well, so
Can I follow up? On that?
I bet you have something to say.
So I was in charge of the implementation of the High-Tech Act around healthcare. What does it mean to be?
Is that for everybody who's not following the work of your excellent work as Office of National Coordinator for Health IT and the High-Tech Act? Is the
There was $30 billion from Medicare to encourage physicians and hospitals to adopt electronic health records. And my Office of National Coordinator, was in charge of setting the policies and the standards for the electronic health records. And we did include, and a lot of the requirements that people grumbled about the most were the public health requirements, that you have to send immunization records, that you have to send syndromic surveillance, that you have to send electronic lab reports. And we did actually, like, those systems very much became essential and useful during the pandemic, except nobody funded the public health departments. So we funded the doctors and the hospitals to implement the technology. We created the standards for those to go over, but we didn't fund the public health departments to be able to be those catchers midts and to receive those. And what I worry about is a lot of the funding for public health informatics came after 2000, when there was a flood of funding around fears of bioterrorism. Nikki Lurie remembers that, right? And we went from like a short-term flood of funding to neglect. And I'm concerned that after this pandemic, we're going to go right to neglect. We're not even going to go to the flood of funding followed by neglect. We're going right to neglect in terms of funding of state and local public health capacity.
Yeah, we're going to turn to that topic a bit too in the next session, and Senator Burr is going to join us and hopefully tell us a little bit about what he sees as outlook for neglect legislation like PAPO or neglect. I gotta say, I don't think the outlook looks great for large scale new infrastructure funding for public health, unless tied to something more compelling. We did a report.
More compelling than what?
Let me say what I mean. So so I think there's complete agreement about the importance of having data on situational awareness for public health threats in a community, whether it's emergency or otherwise. We did a report recently with Healthcare Leadership Council, where I can't tell all you all how strongly healthcare organizations feel about making data available to help with public and population health responses, which, back to Farzad, your earlier point, today are healthcare and public health combined. It's hard to imagine a response to any of these major health threats without healthcare playing a big role. So they want the information too. I think the concern is that without an interoperable infrastructure, as you were mentioning, Anne, at the public health agencies that each have their catcher's mitt in the face of a lot of information flowing in, is there a more efficient way to get that data to everybody who needs it for an emergency response? And that led to this proposal of a potential third-party contractor working with CMS on data that are collected through exactly the systems that you set up. So it was national coordinator standards implemented with the support of CMS, either conditional participation requirements or meaningful use then, or appropriate use of interoperable electronic technology now. That would be available to everybody quickly. The healthcare responders, the public health agencies. If we have limited resources for public health, is that the best infrastructure to buy in the short term, sort of replicating the ability that we already have to put these data together seemingly right now or very soon, or is it putting some infrastructure into helping public health agencies analyze it, do something with it, providing the data that the Center for Forecasting and Analysis at CDC desperately needs to do its job effectively, and supporting the guidance and the insights that would come out of that work?
I mean, I think it's both. I mean, I don't think you can do one or the other. I mean, I get asked all the time, like, what do you learn from the pandemic? And there's like all sorts of different things, but I oftentimes say informatics, information, and incentives are kind of three major buckets. And I think that the informatics and the basic structure, at least having standardization of what is shared, what isn't shared, to be able to do that space. I think that if we better align like what CMS is doing and what CDC is doing, but also don't forget SAMHSA and HRSA, like FQHCs have a ton of data that they're really doing in population level. And none of that is coming over to the state level to be able to look at, or local level to look at population health. And they're doing amazing work in that space. So I think we look at those funders, and how do we look at grant funding as almost the magic pixie dust of the healthcare system space to help realign the train tracks of healthcare to move towards population health. But instead, as I mentioned, we use a lot of this grant funding as kind of the, little kids with their finger in the dike trying to hold the dam together rather than thinking strategically about how we want to move forward. And I think we build that in to our grant funding. So, like right now with CMS and health-related social determinants, social needs, their 1115 waiver, making that a part of the grant application that's CMS or CDC, like once the state health department gets from CDC, what are you doing about health-related social needs? And you must be engaged in your state's process of looking at the CMS waiver. It then forces states to be able to say, how can I use this grant funding to be that public health 3.0, to be that chief strategist for how we can do population health. And I'm going to work with the larger systems of CMS waivers and the rest of it to be able to align that. But if we don't build that in to our actual infrastructure, it's not going to happen. And then how do we translate that to information? So it's not that I'm just catching that ball, but I'm also able to throw it back out. So I'm able to get back out to the healthcare team population level data on their vaccines. So my clinic can schedule 15-minute longer appointments for their unvaccinated children that they're able to get back into the data so that they can actualize that. Because then I think it gets into incentives. Yes, we can look to Congress, and yes, that funding is going to be absolutely critically important. But I think, healthy people are cheaper people. Like there is other incentives besides just do good, but there's also financial incentives to moving this direction. I mean, we are the most expensive nation for cost per care, and we can use those dollars more wisely. And so I think, how can we use public health information, data, science to help to get healthcare outcomes that we all want to see, so that you can increase your vaccine rates and use the incentives of the healthcare industry, incentives within public health to make sure that that is moving forward.
And we're going to talk some later today. And Farzad, I know you're living this at Aledade now about, as Celine mentioned, the shift towards accountable payments in healthcare that could be tied directly into things like reporting on case rates, and also importantly, reporting on what's been done about treating those cases. So we'll come back to that as well. I'm just wondering, Celine, back to your point about the need for more support for public health too. Instead of all of these grants going from CDC to different specific issues in public health, are there a few bigger ones that are like most important to make measurable progress on now around addressing some of these public health threats, something that wouldn't just end up as Anne, I think you were saying, is maybe not really amounting to a clear and measurable impact on population health?
Well, one problem is our funding is too siloed for specific diseases, specific conditions. So for example, during COVID, we also had MPOX last summer. The lack of flexibility in being able to reallocate funding, particularly when you have perhaps overlapping activities, services, to be able to have that kind of flexibility, I think would be important. I also think we have this moment to reimagine what is public health. I think historically we have thought about it as everything that was happening outside of a healthcare facility, but that's really changing, right? With telehealth, you have community health workers that are being employed now by both healthcare systems and public health. And to reimagine it as a less perhaps direct service delivery arm, assuming we could figure out ways to reach those hard to reach and uninsured, and to be more strategic, to be the one that is taking in that data, analyzing that data, perhaps also pulling other streams of open source data. So Bureau of Labor Statistics data, Department of Education data, to be more creative about how we think about responding to public health, thinking really more upstream. I've always thought about healthcare really focused on the downstream, public health upstream, and social services, community-based organizations somewhere in the middle. And I think, unfortunately, public health has had to bridge all three in some ways. And to really be able to focus on those bigger picture issues of regulation, how do you create a healthier community, instead of focusing on how do you refer to social services to get somebody into housing, how do you get to more affordable housing and healthier communities? And I think that's a lot in the regulatory space as well.
Yeah, in terms of putting that together, so healthcare, for reasons we've talked about, seems to be moving upstream, not at the pace that I think you all would like, but we'll come back to that today too. That's close to $13,000 per person in the United States today. It is now getting more inclusive of community health and integration with social services too. Social service spending over $3,000 per person in the US. We've got more of a shift towards healthcare versus social compared to other high-income countries. But both of those numbers are still way larger than the several $100s per capita that we spend on all state and local public health activities. So it does seem like your point about where to focus those public health resources as there gets to be more maybe accountability and focus on population health and what we're doing in healthcare and social services would matter. But it's hard to do that, as you say, with public health also being responsible basically for frontline care delivery for people who fall through the cracks or are forgotten or left behind by our current healthcare systems. And that gets to, I think you brought up funding from HRSA and SAMHSA for federally qualified health centers, other safety net organizations. Probably number one funder of those organizations is actually Medicaid. Can the public health job be made easier by getting to some more accountable care and accountable population health for healthcare providers in that space?
100%. And I think part of it's cultural. I think we need to we don't know what we don't know. And I think public health doesn't know what healthcare is doing and healthcare doesn't know what public health is doing. So I think there's a huge cultural divide there that we're going to have to bridge. And that is on a day-by-day conversation and trying to integrate. I think also in incentives can align that. I think we also need to be really careful about who we're leaving out of these conversations. When we for example, Alaska, 65% of our state is not even in the federal health equity zones. Like we're not even on the map. We're too little to be quanted. And so then we said, well, how much
is that just like blank space
It's blank space, right.
one of these heat maps?
Not to pick on Duke, but we're not actually on your map. But we oftentimes in the need for efficiency or graphic designing, it gets.
I just made a note to update the map.
Sorry. That happens all the time. We joke all the time. If we're on a map, we're really excited. But we looked at how much vaccine and how much therapeutics were happening in our undetermined zones. And in Alaska, it was somewhere between 15 to 20% of all of our vaccine delivery and our therapeutics were happening in equity zones that were too small to be determined. And if you look at that as a nation, about 1% of the nation is in zones where there's not enough information to even determine health equity zones. And every day there is about 1% of the vaccination and therapeutics that are happening in those regions. So I think we always have to be asking ourselves, who are we leaving out of this table? Who else is in that conversation? And it's much easier to do these things kind of at a system-wide when we make these things. But I think what has happened is it's just made us more fractured and more siloed. So how do we make sure we all want to be a part of accountable care organizations? Right, I'm part of the Department of Health, but we're accountable. We're accountable to the public. It's a different accountable care organization. But we all want value. We all want sovereignty. We all want independence and respect for our own decisions. And we all want to make sure that we're moving as collectively as we can towards a healthier, and I mean, maybe not all, but most in that space. So how do we make sure that health departments are accountable for their care? How do we make sure that they're thinking about value-based care? And how can we take this tremendous knowledge that's happened with some really innovative work that's happened in healthcare and partner with public health to be able to utilize each other's strengths and weaknesses to move forward?
I would like to come back before we end. We have a few minutes left. It's a great discussion. Like you said, it seems like a really good question. I'm not sure we have all the answers, but great discussion and great sense of direction to come back to what should public health agencies be accountable for in the 21st century in this kind of evolved model of public health, population health, and healthcare and social service involvement. But I do want to come back to your point about, now I feel bad about Alaska not being on that.
Sorry.
map.
My mouth does.
As far as I'm not sure if Aladate is in Alaska yet, but you are going into, you are in a lot of rural areas where there isn't a public health agency to speak of. We've seen some innovative programs around the country where local public hospitals in rural communities that are really struggling now have stepped into playing more of a public and community health role in some of these issues with some funding streams that are kind of directed into a combination of public health and healthcare. From a rural health standpoint, what's we can't have public health agencies, at least the traditional ones, everywhere.
Many of our physicians in the rural areas are also their local county health officials. The family medicine doc who, delivered the baby and has the end of life conversation is also the county health official. And they are absolutely on the front lines. And one of the things I just want to be sure we all, I'm all about the data, right? And about the national flows of the data. And we have more and more consolidation in healthcare, consolidation of data flows, and it makes sense to think about centralizing a lot of that data collection analysis. I'm obviously in favor of doing that. But at the end of the day, though, when you detect something that might be a cluster of cases, there has to be a person who goes and investigates that. We can't just have fire alarm smoke detectors all over in Washington, D.C.
Some support for
And then
those local.
There has to be, we cannot, tech our way out of the need for support for the state and local health officials and the capacities that they have. And I'm sure ASTO and CSD and others are fine with having accountability, but you can't just have accountability and no funding, right? And what it really worries me, if literally in 2023, we're saying there's not going to be money for public health. And the tech and the data is a small part of it, but having some relief for the state and local public health officials who are the local responders is what concerns me the most.
And what do you all see as a feasible way to get there, given
health insurance tax? Reintroducing the 0.5% health insurance tax.
Okay, health insurance tax. Proceeds going to. I said feasible. Health insurance tax with proceeds going to state and local public health with some new accountability for being there for.
Yeah, that's my dream.
Well, I would also add Medicaid expansion. If you have Medicaid expansion, you can offload some of what is falling to health departments now, where they can focus more on the epidemiology, the surveillance, and sort of the core activities of public health.
Now, that was part of our justification in North Carolina. It just passed, I think, the first state that has a strong bipartisan vote. It's work that Mandy Cohen, as I mentioned before, had been involved in, along with us and many others, around shifting the conversation to being about accountability for health and paying for better health in exactly what you described, with some expectations of measurable progress around children's health, maternal health, and tracking these public health challenges. What else should public health be accountable for to help sustain and increase its ongoing funding needs?
Well, I mean, I agree that we have to make sure that it's funded to be accountable for. I mean, I think right now.
But you're telling us about a lot of things that healthcare needs to be more accountable for, and it could increase Medicaid, could be a basis for Medicaid expansion. How does public health accountability fit into that?
Yeah, absolutely. I mean, I think if you were to look at kind of along the lines of an insurance tax, if you had some sort of increment fee that came as part of insurance, when we get a funding from CDC, we have an increment fee that we take off to do the administrative work that needs to get the grants, the procurement, and the contract and the HR out. I think that public and state health are essentially a service that you're providing to healthcare in the same way. I'm going to make sure that you've got vaccines in your community. I'm going to follow up on that TB case. I'm going to follow up and understand the science and get information out to your healthcare providers that we now have this new disease called Mpox. I am providing a service to the healthcare community. And just like we have an increment fee that comes in, I think there needs to be an increment fee that happens that then helps to fund public health, because you're benefiting the health and the healthcare system in that space, so that that one syphilis case has follow-up on that patient and helps to detect all of their close contacts, so that you're not just seeing more people in your emergency department with secondary syphilis or tertiary syphilis that you're then having to figure out how to hospitalize later. So they go right hand in hand together, but we have to see value in public health for the real economic value that it adds to healthcare, not this like thing in the corner in the black box over there that shall do some work. And then when there's a big pandemic, we'll bring them out and see what they want
Are
to
there
do.
ways other than health insurance tax? So just to give one example of an area
We
where
can
there's
strategize.
so healthcare, that's 2 votes for that. That's like at least. Just to throw out another potential approach. So right now, healthcare organizations are doing a lot of the work around surveillance for emerging antimicrobial resistance. So that's data that comes out of, because many of the serious cases are in hospitalized patients. That's data that the hospitals collect and have a system for sharing with CDC for tracking regional trends. And it's not as complete as it should be, but it seems to be trending in the right direction. That's something that healthcare organizations and their payers seem willing to pay for without having to go to a separate tax. It's tied back into their ability to manage infectious disease risks. Are there ways to build in more connections between healthcare and public health financially in these regards?
I mean, I think there's like
Or
so
are you gonna
many.
stick with your insurance tax?
I'm thinking.
I think there's a ton of different levers, and I think it's going to have to be done at numerous places. I mean, I think like the condition of Medicaid is like one. I think a tax is a separate one. I think building in, I think that like the CDC, like the EIS officers, like that is an example of where a federal agency sends people out to states, engages in the local state world, and then goes back federally. Can that happen with SAMHSA? Can that happen with CMS? Can that happen with HRSA? So that they come out and help us, and they have kind of a fellowship from behind. Can we not just have a US digital services for the federal government, but can we have that for a state and local to help us with the IT, so that business and industry can come see what it's like there and then go back to their business and industry to have it happen? Can you invite the state and local epidemiologists to your healthcare industry, like to look at your data and to actually see what that looks like? I spent so much time early on in the pandemic at our local health department or our local health, like Providence Health System, these big health systems, looking at their data, because it was the only data I could see to be able to make any sort of decision. The governor's like, I need to make a decision today. My epi team's like, CDC hasn't told me anything yet because we're still having the data. Everyone wants to see the me within the we of data. It's got to be actionable at the local level. And a lot of the healthcare sector has a lot more of that information. So just even inviting them in to be a part of it, or even as a healthcare industry to deploy someone to your local or state health department for a year or two, and to be really that liaison to your health department on how do you communicate that messaging back to clinicians. I mean, it would help us so much as a state and local to figure out how to connect to the health department and vice versa. So,
and some good reasons and good new supports for doing it. So Anne, Farzad, Celine, I promised at the beginning that we weren't going to get answers, but you actually have some like good directions forward, maybe an insurance tax, but certainly other steps that will help healthcare and public health work better together. I want to thank you all for spending such a rich discussion and provocative discussion on Farzad, what you said. This is the right question for population health for the United States. Thank you all for being with us today. Thank you. Thanks. All right, I think we're ready for our next panelist. I'm looking to see if there we go, Senator Burr. Senator Burr is a longtime colleague of ours. He may not remember, but he actually joined us. You joined us, Senator, for the first event for Duke-Margolis when we launched this program, now coming up on 7 years ago. Thanks so much for being here. It's great to see you.
It's a great diplomatic way of him calling me old. I know you probably don't remember this.
Well, it's good to see you again. And you have moved on to a new day job, working now as a principal policy advisor and chair for health policy strategic consulting at DLA Piper. But I also know from work that we've been doing together that you're still very involved in issues of emergency preparedness and response from a healthcare focus. So I wanted to talk a bit about that and especially where we go from here. So as we discussed with Ashish Jha earlier, the COVID-19 public health emergency is ended. People want to look forward for the nation's preparedness and response for public health emergencies. And the big next thing on the agenda for that is the reauthorization of the Pandemic and All Hazards Preparedness Act, PAPA. You've been following that closely. You were involved in the PREVENT bipartisan legislation, some of which made it into law late last year. Other provisions of that are also being considered now. What's the outlook? Where are we on preparedness and response?
Well, thanks for the invitation. And you know, it is a little bittersweet to see that PAPA's up for reauthorization when I wrote it in 2006. So we've been through
Yeah.
a number of reauthorizations. And the great thing was that in 2019, when a pandemic hit, we had made the changes that we learned over the progression of PAPA so that it was current. And I think the challenge now is for my colleagues on the Hill to look at what we've learned post-COVID and what the domestic and the global infrastructure looks like, and to design to reauthorize the new PAPA to think about some of the things: scalability, diagnostics, surveillance. I mean, I can mention all of these things. I think the one big change that I made, Mark, is I got it wrong in 2006. I created the Assistant Secretary of Emergency Preparedness. By statute, that person was there to run any pandemic response. Well, I went through 4 administrations and nobody chose that person to run the response. H1N1, H5N1, Ebola, MERS, SARS, COVID. I thought that would work, and it didn't. So in PREVENT, we create a mission control in the White House, because whoever's directing the pandemic response has to speak with the authority of the President of the United States. And this was the only way to accomplish that. Now, I don't want anybody to get the impression there's not a role for ASPR. There is. It is absolutely crucial because so much of the architecture is built under the ASPR. But from a standpoint of the combatant commander of a pandemic response, that's got to come out of the White House. It's got to come with the authority of the president. And it's not something that you can leave to sort of bounce around in a multiple HHS agencies. And clearly we saw everybody involved. We saw some hit thresholds we never dreamed they could do. And we saw others that quite honestly didn't even live up to the dismal expectations that some of us had.
Now, in terms of this mission control for pandemic response, and hopefully we won't have any, but other big cross-cutting emergencies that require not just HHS agencies to work together, and we've talked a lot about how important CMS is and healthcare is in emergency responses now too, but FEMA, other parts of government. Are we there yet? There was just another GAO report suggesting that big gaps in coordination. We're going to talk about this in our next panel too. What is needed to get there?
Well, I'm hopeful that the coordination piece is mission control in the White House, because now there's somebody that speaks with the authority, and you haven't got 5 agencies looking at a secretary of HHS saying, "What do we do? How do you and I learned a long time ago that even within those agencies, it's hard for a director to pick winners and losers. Even if the threshold was, if it benefits the health of the American people, then surge this money over here. But an NIH director can't do that because he owns all the pieces parts. So you actually had to have somebody on the outside of the HHS enterprise to run this. Are there places that we still haven't thought of? Sure. I'm hopeful that those will become visible before they do the reauthorization. They've started the hearings. You and I both know the timing on the Hill means they've got to have a bill out of both the House and the Senate by the time they leave for August break, so that it can be negotiated if they want to get it before the end of the year. And if they don't get it before the end of the year, presidential politics overtakes in 2024, nothing happens.
Yeah. Are there other critical elements that need to go into that bill?
Oh, listen, there are a lot of things.
What's at the top of your list?
I'm more concerned with surveillance, diagnostic capabilities, anywhere where we can surge technology to really alter the landscape. I heard you talking about public health earlier.
Yeah.
Not to rehash that debate. You know, when's the last time we talked about what technology can disrupt public health? We still do public health the same way. And I've heard the debate on taxes. You know, healthcare data is a valuable commodity in a global marketplace. People will pay a fortune for that data. We have to figure out how to make that data marketable in some way, shape, or form. You may find out how to finance additionally an expansion in the public health landscape. So this is not rocket science that we're working on, but you can't reauthorize PAPA and not do it with a vision for 5 years from now.
Yeah.
Or for 10 years from now, or for 15. I like to say, I'm hopeful that this is an architecture between Prevent and PAPA, that 10 years from now, if it's needed, it will be applicable. We found out that we went 14 years on PAPA. And when COVID hit, that architecture was there. And if it hadn't been there, we wouldn't have had a vaccine in 12 months. There are a lot of things that I think everybody who was involved with it, and Dr. Jha has been incredible what he's done, and I hate to see him leave. But so were people from both administrations. And I think that's the unusual thing. I'm not sure we've ever had something like this where we actually praised people from two different political parties and two different political executive branch entities.
You know, it is a good sign for preparedness, but I do want to push a bit on your point about the increasing role of diagnostics and biomedical innovation generally. I think, Senator, the expectations from here on out would be that thanks to biomedical progress, we should be able to have diagnostic tests available very quickly, potentially at scale, soon after, repurposed treatments, and maybe even, you know, bioengineered treatments like monoclonal antibodies, and then vaccines and other countermeasures. All of that suggests that healthcare is going to be a critical part of the response, including even at the surveillance stage. You've served on both HELP, and I remember back from your House days, Energy and Commerce. So you also have a foot squarely in the healthcare world. Are we doing everything we can to help healthcare support these emergency responses? I ask because, as I mentioned earlier, we recently released a report with the Healthcare Leadership Council that had recommendations for how to make healthcare and public health better coordinated in emergency responses, starting with providing diagnostic data and being an integral part of that surveillance and initial containment system.
Listen, if there's, and I'll speak at Fiddly tomorrow, if there's one glaring thing that we got wrong, it's that government provided no transparency throughout COVID. So we were given guidance to individuals and to parents and to schools and to hospitals with no transparency on the data to allow maybe academia to research the data and see if they were confirmatory on it. Big mistake when you get in something like that. And that's something we identified when we put together the anthrax legislation in the early 2000s. But Mark, you're exactly right. More of what we have to do in the future is have off-the-shelf technologies. We have to have countermeasures that are in the inventory for an identified potential threat from animal to human. Anything that we feel could go into the classification of pandemic. Some of that research is being done. Not enough of it, in my estimation, because as we've learned with vaccines, one, if you haven't got the platform, then it's 2 or 3 years just to get the secret sauce. And the platform may not work for the next one unless we've got another platform. And so when we look at this, the arsenal has to be all the above. It has to be single molecule oral medication. It has to be nasal. It has to be monoclonal. It has to be vaccines, both traditional and new technology. So when Dr. Jha talks about next gen, a $4.5 billion commitment to next gen, if it truly goes to next gen, this is a game changer. But you and I have been here a long time.
So you make sure that
We
happens.
know how this money is either going to be rescinded by Congress or sucked up into some area that isn't worthy of an additional dollar. And I will tell you the toughest thing, having gone through COVID, the thing I was most vocal on was the CDC and the lack of surveillance capabilities. Surveillance in the 21st century is not processing 7-day-old data that you got from a county to a state to CDC. That's the same crisis management mode this town has worked in for the past 5 years. And what we've got to do is we've got to get health research back to science, and we've got to get health focused on getting out of the crisis management architecture that they've put us in up here. And healthcare has to be 100% visionary. We've got to drive this as fast and as far as we possibly can. And we've got to ask regulators to show the same type of flexibility and quite honestly, vision that I think innovators are going to show. If we do that, we're going to be in a much better shape on the next one.
Senator, thanks for joining us for this discussion. I'm not sure we're there yet in having healthcare and those biomedical capabilities that are ready to go, but I'm really glad that you're staying involved in helping make sure that PAPA goes well and that we're prepared for these next threats.
Mark, if there's one comforting thought, and it's not just limited to the United States.
Yeah.
There are a hell of a lot of smart people in this world. They've just got to be tasked as to where to direct that intelligence. I think they're going to do it.
Thanks so much for being with us. Thank you. It was great. Look forward to following up. All right. Thank you, Senator. And now I'd like to bring up our panel to follow up on some of these topics related to preparedness and response. And if you all could make your way up, Phil Zelikow, who's White Burkett Miller Professor of History at the University of Virginia and Executive Director of the COVID Crisis Group. There you are. Nicole Lurie. Nikki is Executive Director of the Preparedness and Response at the Coalition for Epidemic Preparedness Innovations. Beth Cameron, Professor of the Practice and Senior Advisor to the at the Pandemic Center at Brown University School of Public Health. Yeah, if it said anywhere, I don't have any. I don't have any seat in order. And Bashara Kosher, thanks for coming all this way, Senior Vice President and Chief Health Officer at Kaiser Permanente. And Philip, I'm going to start with you. Our center and I were glad to contribute to your recent book, which has been getting a good deal of attention.
Oh,
lately
you mean the
as
book called Lessons from the COVID War?
Yes, that one.
Published by Public Affairs
Do we have
and
a
available in all bookstores?
we have a QR code for that? Like, and that book exactly, which touched on a lot of the issues that we've talked about here already in emergency response. And I know this is about emergency preparedness and response, but I do want to link this back to some of the earlier discussions too. You just heard what Senator Burr took away from COVID-19, particularly highlighting some of the surveillance problems with traditional public health approaches there. You've spent a lot of time on that, on many other issues, trust, everything else that came up. I can't ask you to summarize the book in just a few minutes, but I have seen you do some really good interviews where you make some very important points very concisely. So let me turn to you to start off this discussion.
Sure, no, and thanks. And thank you, Mark, for being one of the co-authors of the book and a member of the COVID Crisis Group. Your insights were really important with your colleagues. People do ask me to try to summarize the big takeaway from the book. And I say, well, it's really a story about preparedness. Now, that's preparedness. If you want, like, what do you mean exactly by preparedness? Read the book and there are like a dozen illustrations of concretely exactly what that means. Preparedness, to put it very simply, means you've really thought ahead of time about what to do and you are prepared and able to do it. Notice what this doesn't stress is, oh, it's all about better science. or it's all about appropriating more money. The United States had the best science and spent the most money and got for that some of the worst performance in the developed world. So where did we go wrong? In almost every respect, if you look hard at where we went wrong, it was this issue of preparedness. And it was the issue of being able to do stuff. And then knowing take, for example, just to pick one easy illustration. We hit the surveillance issue 3 different times in the report in different contexts, and I won't go through that, and Senator Burr was right to call that out. But let's just take, for instance, the issue of tests. Everyone knows that we didn't have enough tests. So we didn't write the report to tell people what they already knew. Everyone kind of knows a little bit of the story about the CDC actually quite quickly came up with a good initial test design. They made refinements to it that botched it, and they had no capability to manufacture it at scale, and they didn't have the parallel lab processing capability to work at scale either in a timely way. But all of you kind of know that story already. Just suppose, for instance, that we were able to manufacture the test successfully at scale, as fast as the Germans did or the South Koreans did, and that we had 100,000 tests available in February and 1 million tests available in March. We had no idea in particular what to do with those tests. Take a moment to think about what would you do with those tests? Well, are you going to deploy them for biomedical surveillance? Okay, what would that whole system of biomedical surveillance look like employing those tests and that processing capability? So that's one idea. Oh, how about the idea of let's use it for point of care testing in order to protect people in nursing homes, where we suffered such fantastic losses in that first year? Or how about let's use testing in order to keep schools open, especially by the fall, and also to make essential workers safe? Or how about we use tests to open 10,000 drive-through testing facilities where anxious citizens can find out if they're sick? So I've just defined now a series of different things that you would have to do. Now, for every one of those things, I would actually have to specify designs and protocols that would go with those. I'd have to allocate from my tests, how much tests go to that. I'd have to line up the FDA to give me the approvals I need that line up with those intended uses. And then I'd have to line up the financing for the tests to be behind that, as well as, of course, the processing capabilities for the timely results that I would need. So what I want you to, by the way, none of that was ready, and none of that was ready for months. Arguably, actually, none of that was ready for more than months. None of that was ready for a year or more, except in scattered cases. Point is this, is all of you thought you'd heard about the testing problem, and that the testing problem was, well, we didn't have enough tests because the CDC screwed up the design. I'm telling you that having 1 million tests in a warehouse is not preparedness. And this is an illustration of what we mean by preparedness. And there are many more illustrations like that in the report. But another thing you can observe is that solving this problem of preparedness does not require some utopian scheme of congressional legislation. It just requires you to roll up your sleeves and get down to cases and work them piece by piece. And you'll actually see when you read the report, there's a ton of low-hanging fruit, a lot of which can be done in existing structures.
Yeah, and let's try to build on that. And I don't want to oversimplify, but taking your example, it seems like a combination of what to do. So some coordinated planning for that includes public sector, private sector, since we've talked about that's going to be a key part of the response. So what does the mission control look like? And Senator Burr talked a bit about that, and maybe we can expand on that too. And then how to deliver. So there's the issue of having these capabilities like the tests, and for that matter, the treatments and eventually the vaccines, and then delivery capacity. One of the themes that's come up a lot is that we have potentially a lot of delivery capacity in our healthcare system, maybe better coordinated with public health. We're just not very good at test to treat, or in this case, early diagnosis, even though that is exactly the goal of many of these population health oriented reform. So maybe Nikki, since we spent a lot of time thinking about this together, of how healthcare testing ability, treatment ability, and data can support and coordinate an overall response. Maybe you could talk a little bit about that. And then I do want to get back to the mission control aspect of this too.
Yeah, no, sure. And I think, Phil makes such great points. One point that I think I might add to his is most of the stuff you have to do in some way, shape, or form, you need to do every day to run our healthcare system and to run our public health system. And the idea that preparedness is some entity, something separate and apart from what we should be doing every day, in my mind, is a really misplaced idea. You can't take stuff, keep it in a closet until there's some crisis, take it out of a box, dust it off, turn it on, think the batteries are going to be good, whatever it's going to be. A really good response builds on day-to-day capabilities. And so if you have a rickety day-to-day system, whether it's public health or a delivery system that delivers really rickety services to people on most in need, you're going to have a rickety response. And that is exactly what happened. I'd go a step further before I go to the data mark and say, CDC could have been perfect. And state and local public health is so incredibly underfunded and dismantled that we still would have failed to deliver to the American people what it was that they needed. So I think we have to think about this much more holistically. You and I have been talking a ton about data, right? And we've been talking about the fact that, as we heard in the last session, I think, the travel of data from the person through state and local public health to the state to the federal government, where it hasn't been turned around and fed back, is just not an acceptable situation. It's also the case that there's a ton of data already in the healthcare system that can help with this. And even before the CARES Act granted authorities to the federal government to require data collection for tests or for healthcare systems to report on their status, large payers like CMS had a ton of data. They could have drawn you a map of the country about where people were admitted to the hospital for COVID. In fact, there was an advanced analytics group, an artificial intelligence group at DoD that worked with a group that had CMS data, and they forecast where COVID was going to go in the country and what hospitals were going to be the hardest hit so that they could supply them. That was preparedness. It wasn't a day-to-day function. It never got out of the closet and got dusted off and used. So we have a really big problem. But at this point, I think what I would say is between the healthcare system and laboratories, we have just about all the data we would really need to manage an emergency. We don't have the system to make the data travel. As Dr. Zink said, we don't have the catcher's mitts ready. We don't have the workforce ready. And we still have people who are analyzing data on spreadsheets and drawing graphs or hoping your Excel program will draw a graph. I mean, if you talk about what machine learning and AI are for, it's for this right now. But I would say right now, we ought to have the authorities to get the data that we need, both from laboratories and the delivery system. CDC is going to fly blind until it can get data, right? Get the data that we need. And you and I have talked in this paper about how CMS authorities in particular could help us get the data, aggregate it, turn it around into maps and heat maps and other data that rapidly get fed back to states and locals, to hospitals and to communities themselves. If all of these data are de-identified, there's no reason you can't put it on a map and share it. And then everybody can see the same information and have a good debate, as Senator Burr said, and make decisions about it.
Yeah.
That's not happening, but there's precedent. We did this previously with CMS data for people who get in trouble on hurricanes and tornadoes and who live with electricity dependent devices. You could do it. You can make a map of diabetics. You can make a map before people have heart attacks. You can make a map before opioid overdoses occur. You can do this day to day. And then if you've got that capability, you are ready to do it on game day.
And I would recommend for those of you who are seriously interested in this topic, that paper with Nikki Lurie and Melissa Harvey and some of the Duke-Margolis team does lay out a path forward, and it reflects a lot of ideas from the Healthcare Leadership Council and places like Kaiser on where these healthcare organizations do have really good data within their organizations. We just don't have a smooth and fast and reliable mechanism to make it actionable for everybody at the community level.
One more point, which I heard about last night, which is that I gather that some of the opposition to making these data are available are that some people are afraid that the data are going to be used to impose lockdowns or to take people's civil liberties away. In fact, I think it's just the opposite. These data are used to make sensible decisions, so you don't have to do blanket policies and blanket decisions that don't make any sense, and that you can with surgical precision. We talk about precision medicine. Let's talk about precision public health, right? With precision, you can put in place the kinds of recommendations and the kinds of policies you need. And so I think that that fear is really misplaced, and I want to call that out because it's an active debate right now.
Thanks, Nikki. And Bashara, you've done work along these lines at Kaiser in your role as Chief Health Officer there, previously worked in the White House on COVID-19 response, and currently involved in some efforts around this goal of healthcare, public health, working better together in emergencies and maybe beyond. Thoughts you'd like to add at this point? Does this seem like a constructive directions in response to Phil's challenges?
Yeah, and thank you, Mark, for hosting us. It's great to be here with everybody. And I think the theme that we've been hearing for the last hour and a half or so has been truly about what should we do more to strengthen that interface between public health and healthcare. And for the last year or so, since I transitioned from my role at the White House as vaccination coordinator, we've been working with a coalition in the healthcare industry to see what is it that we can do to really partner with public health in a different way, so we are, one, better prepared for the next pandemic, but most importantly, so we can deliver better for our members, our communities, our residents in non-pandemic and non-emergency cases. That interface is so critical. So back in March, we have launched a coalition that includes the American Medical Association, the American Hospital Association, the Association of Community Health Plans, and AHIP. They came together with KP to try to figure out what are the things that we can do from a healthcare industry perspective to strengthen that interface. And just to Phil's point, there's a lot of things that we can do that don't require big P policy change. There's just a lot of things that are no regret actions. And that group for the last year spent a lot of time looking at what is the evidence behind things that we know work? What would it take to actually get it to work? And we've spent a lot of time, identified about 140 or so policy with a small p and big P policy things that we can do. We narrowed it down through a process and landed on 4 key areas that these partners in the healthcare space decided to focus on when it comes to strengthening that interface. And a lot of this is exactly what Phil and Nikki's been talking about, a lot of what we've heard from Farzad and Anne and Celine earlier. One big piece is, how do we strengthen that collaboration? How do we know who are the main players? Do we have agreements in place with clear goals and responsibilities and accountabilities that are there? The second area is exactly what Nikki was describing about, preparedness doesn't just happen when there is an emergency. We are better ready to respond if we're always ready. These preparedness activities are things that we need to be doing on a regular basis. It's an integral part of how we operate. So how do we codify those, define those, and be thoughtful and systematic in making sure that we're executing on that is another area that this coalition is focusing on. The third area goes back all the way to the data pieces. And I know there's been tons and tons of conversation about the data all along. There's tons of data out there. How does it flow? What does it mean? What are the policies around that? How do we make sure that we're having those conversations to happen in a way that's pragmatic, that's actually leading to data flow that have real-time data, real-time information that would allow us to respond better. And then the last area that this coalition is focusing on is around disease surveillance. And and I think we've heard that all along, and probably Beth will comment on a little bit here on that as well. Disease surveillance is so critical to happen at an uber local level, at a state level, at a federal level, and at a global level, and to be interconnected. So when we discover something, we'll be able to act on it as fast as we can. So that time between discovering a problem and being able to start thinking about treatments and diagnostic and vaccines and therapeutic and others become really, really critical. So I'm really thrilled about this coalition. I think having these four main players in the healthcare industry coming together and realizing that really that interface with public health is so critical on so many different levels, and not just for emergency preparedness. It's just in our responsibility to create better communities and improve health in this country. So I'm thrilled about this coalition. We've just launched in end of March, and we continue to work on these four specific areas. And again, it's action driven, it's no regret actions. Some will eventually might end up big P policy, but there's so much that we can do today that we should be doing.
And sounds very aligned with a lot of the specific ideas that we've discussed around data sharing and support for early intervention and effective population treatment. Beth, I'd like to go to you. So you're bringing a global perspective to all of this. We've heard a lot today about some of the special challenges in the United States. And I guess to paraphrase Phil, the US was different in some not good ways in terms of outcomes here, but some of the fundamentals around the opportunities that biomedical innovations around testing, treatment, and vaccination prevention bring, the challenges in getting those innovations out to people equitably and effectively and timely. Those are even bigger in many of the global contexts that you work on.
Yeah, well, first, thanks for having me, and thanks for what has been said so far. I'll align myself with all of the comments that have been made. I'll say one thing about domestic, and then I'll add the global perspective. First, I just really want to appreciate the public healthcare siloing, which is domestic, but we also silo our programs globally and how we look at these things. And that's one of the reasons that I'm here in my Brown Pandemic Center capacity. I do spend some time at USAID. I'm not speaking on behalf of them today, but the reason I'm doing that is to try to bring some of those perspectives together. I think it's critically important that we look at our programs, and I'll talk a little bit more about that in a second.
Right.
I also want to say that going back to what Ashish said about trust and polarization, I think that if we are bringing public health guidance and targeted public health measures as early as possible with the best data as possible as we can, and we're targeting those tools to help communities keep schools open, to help communities keep businesses open, to help communities increase education around things like vaccine uptake. If we have better toolkits, if we have better playbooks that are aligned with what healthcare providers are able to give in specific communities, I think that will help us with some of the polarization challenges that we have. And one of the things that we're doing at Brown, working with COVID Collaborative and CSIS, is trying to really understand how that worked well in some communities around this country, how we can sustain those infrastructures now so that we don't actually lose them. Moving to global, I'm going to hit just 5 things, some of which we've done, I think, a little bit well on globally, and a bunch of which we really have a ton of work to do. And I'll go back to one of the things Phil said about tests. This translates perfectly for testing. It also translates for vaccines. Even if we'd had vaccines available for everyone in the world, we didn't have a way to deliver them. And part of that is about, a lot of that is about the integration of community health and public health and services, especially in the case of vaccines for adults around the world. So we hadn't rolled up our sleeves and thought through the protocols for how our global health and health security infrastructure would deal with a large scale pandemic. We didn't work it through case by case. And so just 5 key areas. The first is preparedness, financing, and health security capacity. We have programs that the United States funds. We have programs that are funded by countries around the world, and obviously national health governments around the world are funding global health security too. We weren't systematic enough as a world or in our own country at looking at exactly where the gaps were, what the most important gaps were to meet targets like 717 that tells you, are you ready to be able to respond quickly to a pandemic threat? We need to do that more systematically, and United States programs hearkening to a national biodefense strategy target that the president's put out are now tracking towards a 50-country target where countries should be prepared in at least 5 areas. And the G7 has agreed to effectively match that target, but we need to roll up our sleeves and really get down to the details. What does that look like in each country? How does that work with PEPFAR? How are we aligning programs that build health systems towards actual specific metrics? And it is not, it's wonky work. It's hard to explain in a soundbite, but we have to do it. We have to do it more effectively. The second thing is the 100-day mission, something that Nikki and others are very, very familiar with and have done a ton of work on. It's critical that we have vaccine candidates ready. If we want to be as prepared even as we were for COVID, we need to start working on the other viral families now. We had a lot of work done on coronaviruses. We haven't done that work for all the viral families. And we need to be able to do that, and we need to be able to do it systematically. If Senator Burr is right and there isn't money coming, we still need to do it. We need to figure out where the resources are, and we need to align them more effectively to just be very, very targeted and regimented about meeting those goals. The third area, and this is the one I'm probably the most worried about today, is response financing. So we can have all the countermeasures in the world for high-income countries, but low-income countries aren't going to get access to them early if there isn't a way for them to have access, have affordable access, and actually have global health organizations like Gavi, CEPI, and the global funds be able to buy them and transport them and get them out to people in communities if we don't have vaccination programs on the ground to be the catcher's mitt for those programs, as Anne said earlier, to use her analogy. So that whole system, there's a lot of work in the G20 and the G7 with the World Bank. There are a lot of assessments going on. We need to get that done, because if we don't solve that problem, we will have vaccine inequity in the next pandemic, no matter what else we do. And then fourth, and you probably won't expect me to say this, is we have to invest in primary healthcare. Health security is awesome, and I've spent a lot of my career on it. But if we don't have strong healthcare systems, we're going to be sitting in the Situation Room in the next pandemic, not only wondering where the disease is going to be, but which healthcare system around the world is going to collapse and cause, 1,000 other problems for the people in that community, first and foremost, but also for the United States, our national security, and for the world. And so that's critical. We're facing the first life expectancy decrease in decades. We have to get better to survival rates that are better than pre-pandemic rates. And we have to do that to meet the Sustainable Development Goals, or we just won't. And then last but not least is accountability. So I think everyone on this panel has done a lot with accountability. And I know, Phil, that your book was intended to get us at least a little bit further down the track on political will and accountability. But we do need to look at some systems for that. What does that look like? The Global Health Threats Council idea was proposed by the International Panel for Pandemic Preparedness and Response 2 years ago. It hasn't been implemented. It may not be the only solution, but what are the solutions for making sure that political leaders around the world have to think about this issue and keep rolling up their sleeves?
That's some great points in a limited amount of time. I want to thank all of our panelists for bringing some terrific perspectives to preparedness and response and how it fits into, Phil, as I know you and I have talked about before, health security being a broader concept than just security against public health emergencies, but against so many of the infectious disease and chronic disease threats that are out there. We just have a few minutes left. I was wondering if we could go down the line maybe about how to get over this fragmentation around things like developing products and separate public health systems for responding to them. This could be in the vein of how do you coordinate healthcare and public health responses better? It could build on some of your comments, Beth, about accountability. But how do we actually make these systems work better together systematically, at least in public health emergencies? It's clearly an area where Senator Burr wanted to see more White House leadership, for example. Nikki?
Sure. Well, I think back to this set of themes, and I think both Phil and Beth really sort of articulated them well. I think one of the things that's very clear, it was clear from Phil's book, it was clear when we did the work on the Commonwealth Commission on a National Public Health System. In the US government, there's not a single belly button for this. There's not a single place where a public health infrastructure is built. It's not CDC. Public health is spread all over the department and all over the country, where it's built and where it's organized and where there's accountability, just like there's not a place where global health security is built. So for much of this, I think there needs to be a single point of accountability in HHS. I know Phil's recommended, his book is recommended an undersecretary for health security. I would broaden that to say we need an undersecretary for public health and health security and put responsibility for the infrastructure. I think it's great that we are funding 50 countries and developing performance metrics and accountability. How about 50 states and territories with performance measures and accountability? And then it's kind of amazing that we can think about how to tell the rest of the world what to do, and we're not able to tell ourselves what to do. We can say we need response funding. I totally agree with it. We need response funding here too. You can't wait for an emergency supplemental every time. It's too late. But I do think, to your point, there has to be a single point of accountability for all the public health and health security stuff in HHS. And I'm very, very much aligned that there has to be this position and this role and responsibility in the White House.
Phil?
So the roles and missions was a mess at the beginning of 2020. It's still a mess. Senator Burr says that he thinks the White House needs to be in charge. White House SARs are a very common solution to these problems. It might be a good idea. The Biden White House did not ask for that. I understand they're now trying to make lemonade out of the lemon that Congress has given them. We'll see. It could work. Our argument is usually these things work better if they're in a line agency that gets appropriations and partners with Congress. But you have to clarify the roles and missions, and you have to clarify it with an overall strategy and how, and you have to have sheet music for the whole orchestra, and everybody has to know what part they play. But let me stress this point. It's really easy to write strategies in which everyone talks about what we should do. Leadership has two parts. Leadership is about what to do, and second, it's about how to do it. So everybody's really good about sentences that include the word should and the what to do. They're not so good when it comes to the how. And what failed in this crisis is we've done a lot of strategy statements with a lot of shoulds and a lot of goals, and we weren't ready to do the hows. So if it's not practical and you don't have a pathway for how to do it, then it's not a strategy. And if we want to reform the leadership, we can get the organization right, but we have to understand that strategy means you have to have practical ideas for how to get it done.
Yeah. Practical implementation around healthcare, public health working together seems like a direction that your group is interested, your collaboration's interested in working in. It certainly fits with a lot of the themes of recent Duke-Margolis work. Ashar, anything else to add here?
Yeah, I mean, I'll just add one point, which is we have to continue to strengthen the resilience of our health system. And that includes both the public health and the healthcare system. And I know we've seen lots of challenges on workforce and resources and data and all of that. And I know we're going to be talking some more about that throughout the day. But one thing I would add, which is around the importance of helping to continue to build the resilience of the healthcare system by transitioning our system into more of a value-based system. I mean, we've seen that. That's why I'm so excited about Rising Health that we've just launched from Kaiser Permanente to bring healthcare systems together, community, not-for-profit healthcare system that truly believe in the value-based system and take that and continue that journey, starting with Geisinger and hopefully many more to come. So I think strengthening that resilience of the health system that includes both healthcare and public health is going to be really critical.
And Beth, your themes very much aligned with what we've heard about on the US side. So different contexts, but similar themes. You get the last word here.
All right, I'll say two things. One is that the idea of what is the infrastructure globally going to look like is very much also a large topic of conversation. You know, what is the WHO's role? What are the roles of all of these organizations that stood up and did things that weren't completely in their job jar, but they just had to do them? And how do we make sure that we ran the experiment, we know what will happen tomorrow, we know which organizations will jump into the fray, and we know who has funding. We just need to make sure that we run the plays and figure out what would actually work for different kinds of crises. But I will also say on the domestic side, I'm clearly on the record multiple times saying that it is important to have strong White House leadership. And the Biden administration stood up on day one, two things: the COVID response coordinator, the position that Jeff Zients and now Ashish Jha hold, and the office that I reestablished, the National Security Council Directorate for Global Health Security and Biodefense. It's critical to have leadership in the White House. It is absolutely essential. It is also essential to have leadership in the agencies. It's defining that leadership. It's what the incident command structure looks like in a crisis, and practicing it every time with people knowing where their roles are and what they do. That is absolutely important. And clearly, we have a lot of outbreaks to exercise on, and I'm optimistic, Mark, that we
Right.
will get it right.
Glad, very challenging topics. And again, I'm not sure we have all the answers, but I'm glad to hear about the optimism and looking forward. In just a moment, I'm going to welcome onto stage my colleague, Dr. Marianne Hamilton-Lopez, who's going to lead a discussion around one very important US and global aspect of this, which is innovation in biomedical products, which has been tremendous in COVID, tremendous in addressing so many other conditions that, as far as I'd said, used to be in a different public health sphere, and now really give healthcare an opportunity to improve population health. But we don't seem to be there yet either in terms of affordability on the one hand, and reliable systems that get those treatments, those interventions to people in a timely way who need them, both here in the United States and abroad. But right now, I'd like to thank this panel for a really great discussion of some challenging issues and connecting the broader teams. Thank you. Thank you. And Marianne, now you're up.
Hey, good afternoon, everyone, and welcome to the Pricing and Access Reforms for Higher Value Pharmaceuticals. As mentioned, I'm your moderator, Marianne Hamilton-Lopez. I'm the Senior Research Director of Biomedical Innovation at Duke-Margolis, and I am thrilled to be joined by an exceptional panel that's going to share their expertise on these topics today. Meena Shashamani, Director, Center for Medicare and Deputy Administrator of the Centers for Medicare and Medicaid Services. Reena Kanti, Associate Professor for Markets, Public Policy and Law at Boston University. And Muna Banshi, former Head of Global Market Access and Policy at Merck and a Senior Advisor in the healthcare industry. I thought I would provide a few context remarks for those of you who do not wake up every morning thinking about drug pricing policy. But for those of you who are in the audience, that's for you. The Inflation Reduction Act, or we're going to call it the IRA today, was passed as legislation in the summer of 2022. And it's the most substantial drug pricing, payment, and coverage legislation enacted since the Medicare Modernization Act of 2003. The IRA includes several important drug pricing related reforms, including the redesign of the Medicare Part D benefit, and introduces the Medicare Drug Price Negotiation Program. So what does that mean? Well, since its inception for Part D, the US drug market looks a lot different. It's changed quite significantly, especially with an influx of high-cost specialty drugs. The IRA's Part D redesign places an out-of-pocket cap for beneficiaries, and it shifts the liabilities in the expensive catastrophic phase of the benefit, so that the plans and the manufacturers are responsible for more of the cost. These changes have several important implications, some which are intended, and some that might be unintended, and especially for consumers and manufacturers and payer plan behaviors. The full actual impact of the Part D redesign has yet to be played out, and more research will be needed to determine its interplay with other approaches that reduce drug spending and improve value to patients. And as mentioned, the IRA also directed CMS to negotiate the price of certain high expenditure drugs and biologics that had no follow-on competition and had been on the market for several years, 9 years for small molecules and 13 years for biologics. It's the first time that Medicare has been given the authority to directly negotiate prices for certain drugs. Recently, CMS published some initial guidance about the different negotiation provisions, laying out an approach for selecting drugs for negotiation, determining a maximum fair price, and conducting the negotiation process. We're on a tight timeline with the substantial undertaking of price negotiations, the first 10 of which are going to be selected for negotiations by this September. So it's going to be incredibly important, not only to determine a negotiation framework, one that provides transparency and predictability for price determinations, but that is also capable of improvement and evolution and refinement as we learn more and over time. There's going to be a lot of other additional considerations, which this panel will consider, including the potential role of different types of data for comparative effectiveness determinations, the potential impact of IRA on the adoption of alternative payment models, whether that's subscription or outcomes-based payment models that are meant to tie outcomes with payments. And finally, in theme with what we've been talking about quite a bit today, how population health models will interplay in the context of IRA. So with that, we're going to jump right in, and I'll turn this over to our panel. All right, so for our first question, I'm going to look to you, Rena and Nuna, but within the context of what we just laid out as kind of what are the implications of this new legislation, what do you think that, from your perspective, we should be on the watch for as we first start to think about implementation steps?
Yeah, so thank you so much for having me, and also welcome to the all-female power hour. Just to kind of level set on health and public health in particular, there are approximately 100,000 Americans with sickle cell. There are 200,000 Americans that are diagnosed with syphilis each year. There are 1 million people with HIV, 3 million people with Hep C, 2 million new cases of cancer a year, plus all 16 million cancer survivors who are largely taking drugs to stay well and take care of their families, 40 million people with diabetes, a quarter of all Americans with heart disease, half of us struggling with mental health, addiction, and anxiety disorders, and all of us vulnerable to COVID, flu, and other diseases. What do all of these diseases have in common? Drugs, frankly. All of these diseases are fundamentally treated by drugs or vaccines or preventives that are safe, that are effective, and that already exist. The big consideration here is that many of these drugs are cheap. In fact, the vast majority of drugs that Americans use are generic. We actually pay the lowest prices among the OECD for those drugs. So that's an incredible asset to our system and a complement to the policies that have pulled those type of drugs into the market. We also pay very high prices for drugs that are novel. And in particular, there are some drugs for which our system, which is really based on competition, doesn't work. In other words, we pay very high prices for a limited period of time. And over time, those products lose their patent life, they lose their exclusivity in other ways, and competition enters the market, and then we start to see prices come down. There are some drug categories for which we have very limited competition, if at all. And it's those drugs for which many patients, including seniors, are struggling to afford access to their therapies. Think people with diabetes, men and women with cancer every day who are struggling at the pharmacy counter to make their pharmacy bill work along with food, groceries, rent, etc. So really, I think the central organizing principle of the IRA is we need to make drugs affordable for those who need them now. And really, it's the Part D reform, which is the central part or central core of this policy, which is going to drop the out-of-pocket costs associated with many drugs for seniors, and will also push out access and affordability to other drugs and other types of therapeutics that are central. That includes adult vaccines and some other therapies as well.
Thank you so much, Rena.
Thank you.
Mina, I'm going to ask you to kind of respond to the same question from your perspective. And then Muna, I will follow up the same. What do you see also being played out with the same question, but maybe within the industry's boardrooms and kind of those kind of closed office discussions as we're there for looking ahead at this implementation?
Great. Well, thank you for having me here and for the ability to be part of the Female Power Hour. So I think, Rena alluded to one aspect of the legislation, and you alluded to another aspect, Marianne, of the legislation. But when we're thinking about implementation of the IRA, there really are three main buckets of provisions that ultimately seek to make drugs more affordable and accessible for people so they can access the innovations and the therapies that they need. So the first, Part D redesign. And we have hit the ground running, as you all may know. We have pretty tight timelines for implementation. And starting on January 1st, people in Medicare Part D could get vaccines with no out-of-pocket cost at the pharmacy counter. Insulins capped a month supply of a covered insulin product at $35. From there, we are leading up to some more work coming for 2024. First, we bring in insulin for Part B, as in boy, starting in July. And then in 2024, we expand the low-income subsidy program to 150% of the poverty level. So that, again, helps make drugs more affordable for people of lower income and resources. And starting in 2024, when people reach the catastrophic phase of their benefit, they no longer pay anything out of cost. So again, really providing support for people who take high cost drugs. And this all leads in 2025 to the out-of-pocket cap that Rena mentioned, where out-of-pocket costs in a year are capped in Medicare Part D at $2,000, and people have the ability to smooth their out-of-pocket costs over the year to help with cash flow. So, that aspect of the Inflation Reduction Act really does bring improved access and affordability to drugs and really enables people who weren't able to take these medications before to now take them. And I say that as a physician. I led the diabetes management program in my prior role at a major health system. We had patients who were not taking insulin because they couldn't afford it. And the number of people who have called 1-800-Medicare, or when I do roundtables and they're thanking us because now they can take insulin, or they were giving money to their brother to take insulin. Now they don't have to, one woman said, I don't have to give money to my brother anymore to afford insulin. The second provision is the inflation rebates, which aims to discourage runaway price increases in the drug market. That is a provision. The clock started in October for Part D and in January for Part B. And we put out draft guidance earlier this year on that provision, whereby if drug prices increase faster than what would be expected by inflation, then drug companies have to pay that differential, a rebate for Medicare sales back to the Medicare program. So that's kind of that second bucket on addressing price. And the third, Marianne, as you mentioned, is negotiation. And in January, we put out a timeline or a roadmap, basically detailing out how do you stand up this negotiation program. There are various guidances that we're putting out, information collection requests that we're putting out. We provided timelines for that because, again, by September 1st, the first 10 drugs will be selected. And we have been hitting those timelines. We have put out our information collection requests to get comments on the data that we should collect as part of the negotiation process. And we put out our draft negotiation guidance. And I think importantly, and this comes back to some of what Rena was saying, where we're really putting the benefit of a drug at the foundation of the negotiation process, as a starting point to say, what is the benefit that this drug provides, considering things like unmet need, impact on specific populations, and being able to incorporate real-world evidence. And all of these things that I mentioned, we're getting comment on because it really matters to us to be able to hear from everyone who's involved in this area so that we can implement this law in the most thoughtful way possible.
Great, thank you. So Muna,
I just love to build on, I
Yeah.
think, these excellent points being made about the IRA. And I will just try to give voice to the conversations that are going on within the industry. So there are a set of strategic discussions and choices that the industry and companies have to make. And it all depends, of course, on their particular set of programs and what is in their portfolio. And then there are a whole set of tactical conversations that also are going on. And I'll try to give you a color on each of those. So strategically, as was mentioned, there is, as part of the IRA, a set of negotiations that are expected to happen if a product is a small molecule. So think an oral pill, a drug. That drug will go for drug negotiations at year 9. And if a drug is a large molecule, so think a biologic, that would be up for negotiation at 13 years. So you can imagine if you're a company and you have a portfolio of products, you're going to look at your portfolio of assets with that in mind, as well as recognizing that regardless of when an indication is brought to market, the clock starts at the first launch. There are discussions that are going on with regard to what indications to progress, and not only what indications to progress for what program or product, but also what is the sequence of those indications, all of which will play a role in the economics of that product. So these are some of the strategic discussions that are going on. There are other aspects of the law as well that tie all the formulations and the dosage strengths of that active drug all as one. So if you foresee a product that comes to market with a formulation, let's say it's a tablet, but then a subcutaneous down the road or what have you, it all could be pulled together as one drug. And so I think that's also part of the conversation that is going on as folks try to rebalance their portfolio. On the more operational side, some of the comments that were made here in terms of implementation is really what companies are trying to understand. So what will be that framework for comparative effectiveness? How will we get our hands on the data? Will CMS use the data they already have? What would the comparators start to look like? What is the level of engagement that we should expect? And you also have to think about from the mindset of a manufacturer. Right now, they do a ton of work around deciding on and describing the unmet need of a disease state. And that is why they bring a product to market. And that is when the product goes through HTA evaluations, especially outside of the United States. Now, when a product has been on the market for about 5, 6, 7 years, and part of that unmet need has been met, how will that be brought into the evaluation? These are some of the very practical things that companies are beginning to ask some questions around. I'll just touch on a couple of other components as well. The Part D, the redesign that Meena has spoken about, is something the industry really is aligned around. It is the right thing to do for our health system. It is the right thing to do for our patients. We have failed in our mission as an industry if we cannot get our medicines to patients. So this is a good thing. The watch out for the industry is going to be twofold. One is what will happen to the products that are not going through negotiations, but are comparators to those products. Will payer systems impose pricing the pressures on those as well? That's a watch out for the industry. And the second piece is, as payers pick up that 60% of the catastrophic phase, will additional controls be placed on the access of those drugs as well? And those are a couple of the other pieces of watch outs for the industry.
Excellent, thank you. I want to go a little deeper into the how. And one of the hopes that we had for this panel is that it wouldn't be just a reflection of what you might see in the headlines. One idea, this is the best thing versus, oh no, we're in deep trouble, but more about how do we move forward collectively. And so as Meena was mentioned, there's going to be a substantial comparative effectiveness. So I think a question both for you, Muna, and Reena is, how do you see CMS being able to develop this kind of framework that takes into account various types of evidence from various different perspectives? And what would you hope to see further clarified from CMS as we are kind of looking at or researching or making industry decisions from the outside?
Sure, go ahead.
So I started to talk about that. I think the first piece, and I'm really excited about the opportunity for us to leverage this opportunity and begin to reimagine what a real world evidence ecosystem could look like. So you can imagine a very integrated approach by pharma in terms of how you think about that evidence plan from the time a product is going through clinical development all the way through patent expiry. And there are a few things that I think we should be starting to think about. One is there a way for us to be able to link clinical RCT data to real world data once a product comes to market? And with tokenization, that now is a possibility. So that as a product comes to market, we are beginning to develop the evidence. So it doesn't feel like we now have to develop it on the fly with a short amount of time. And I think everybody is able to benefit when we can do that. It allows us to test the hypotheses, ask the right types of the questions, build up the quality of the data, and everybody wins when we are able to move that in the right direction. So I think that's a great opportunity for us to capitalize on. And the second piece I just will touch on is that of partnerships. I think that this is a phenomenal time for us to think about the partnerships between FDA and CMS and the industry. We all are trying to get at the same thing. We all want to drive data-driven decisions to the benefit of patients. And I think if we can put our heads together, make this a learning opportunity, because we all are going at this, we're going to have fits and starts and bumps along the way. I think we have to assume good intent by people. And I think we have to ask ourselves, how can we learn in the process and hold hands and come together and build out this ecosystem for the good of patients? Thank you.
So I agree. And I would say this is a really exciting time and an exciting opportunity. The science of health technology assessment and comparative effectiveness has been around for about 50 years now. And what is really new here is that the vast majority of comparative effectiveness and cost effectiveness analysis or health technology assessment analysis is typically done at the time that the drug or therapy is launched. And it's largely predicated on the results of clinical trials and registries that were developed for approval. But by definition, what CMS here is essentially pulling into existence is a much more robust and focused scholarly effort to think about real world evidence and health technology assessment 9 years, 10 years, 13 years after this product has launched, and in very particular patient populations, not necessarily that of the trial.
They're coming with a microphone.
Oh, good, thank you. Thank you. Okay. Not so. Not at. Oh, hello. Hopefully that will. Oh,
There you
good. Okay. So there's also an emphasis on populations that are not necessarily the ones that were included in the trial, which are usually largely young, largely healthy patient populations. But actually, CMS is asking for real world evidence associated with the use of this therapeutic in the Medicare population, which is older, has comorbidities, has other types of access and healthcare needs at the same time they're being treated for a given disease. And so this is a challenge because much of the evidence that will have already been generated that is easily available off the shelf for these companies to bring to the table of negotiation in the first period will be of that latter, of that former category of like what we know about these drugs in clinical trial population or in real world evidence as it has been brought to bear already. But over time, this is going to pull a lot more effort into thinking about, okay, well, what do we know actually about the utility of these drugs in real world populations? I think that the biggest concern I have is that some of the data elements that have been requested in law and that Mina and the team at CMS have to implement are not ones that the company that is negotiating might actually know. So a great example are the research and development costs of bringing a drug to market. Well, that drug that is being negotiated is 9 or 13 years post-launch by definition. And it is very common for the labeler of the product, the company that's actually selling the product now, to not be the company that actually brought that drug to development. And that's because they licensed it, they acquired it, there was mergers and acquisitions and on and on. And so finding ways that to streamline some of the data elements that are going to be requested so that if there are elements the company doesn't know or the company really had no ability to know, or it's been a really long time and corporations have changed, some way of kind of attesting we don't know and moving on with that so that this doesn't become very burdensome, I think is a place to watch out for.
And the one piece I'd just add on the R&D, the issue there is the concern the industry has is that there will be a cost plus approach being taken to the pricing. And as we all know, by that I mean the cost of the R&D and distribution costs. And and as we all know, the economics of the industry don't work in that way. The 10% of products that make it to the market have to pay for the 90% that don't. And I think that's the other watch out to the point that Rena made.
Maybe I can just add on and say, so Congress gave CMS a list of data elements to collect for the companies for negotiation, but it didn't necessarily give a prioritization of that information. And clearly some of this information is going to be more valuable for negotiation purposes than others. And so kind of finding ways that to provide shortcuts to the industry to kind of get this done, but not necessarily be the most important part or the thing that really, that last nth degree that costs so much money and so much effort to do, or they can't even do it, I think is going to be an important area to move forward on.
Great, thank you. Mina?
Yeah, I mean, I will just add to what both Muna and Rena said. In our draft guidance, we really did have that benefit of the drug as the foundation of what to think about. And really putting forward real world evidence, and where you have drugs that have now been on the market for 7 years, 11 years, right now, at least 7. So how can we utilize that to be able to really get a more holistic view of how a drug is impacting populations, and to be able to consider that and really having that at the forefront. And I will say, when the law passed, immediately we were out there meeting with everyone to try to engage everyone, from manufacturers, patient groups, providers, health plans, academics, to understand everybody's perspectives on how this law could be implemented. Where are the areas of uncertainty that clarity would be helpful? What are suggestions that people have? What are data analyses that they can bring to bear? And I think a lot of those conversations are reflected in what we have put out so far, where, to what both Rena and Muna were saying, there is a huge opportunity here to engage everyone in a conversation about what drugs bring to improving the health of populations, and where what we are doing can help further that conversation. And similarly, to really approach this from as pragmatic and operational a view as possible. I think we've already mentioned how tight these timelines are that are in the law. And we have monthly technical calls with manufacturers, monthly technical calls with plans, so that we can make sure, to some of what my colleagues are saying, that when we are asking for data, is it data that it can be accessed, and what are ways that we can obtain the data that's being asked by us in the law, and getting the input of those who would provide the data. Okay, how do you ask for this, and how does this make sense with your systems of operation? And so thinking about both the policy and the operations together, so that we can have this law have the impact in terms of access and affordability, and really driving the conversation on innovation to make sure that we are rewarding the innovation for the cures and therapies that people need.
Excellent. And are those conversations, knowing how difficult the collection and use of real world evidence can be, are there ways that CMS, by itself or in collaboration with FDA or in these public-private partnerships, as were mentioned, can help incentivize the use of the collection of RWE that can be used for decision-making for the Medicare population specifically? Is that reflected in the conversations that you're having?
Yeah, I mean, in the draft negotiation guidance, we said that we would like comment on real world evidence and what can and should be considered when we're thinking about what benefit a drug brings to populations. Absolutely. And I think also it really is about that partnership and collaboration, both so that we're able to get input as we are developing policies, and then also the partnership so that things actually happen on the ground, right? I mean, we implemented the $35, insulin monthly cap and the $0 vaccine. But if a person on Medicare doesn't know that they can now go get their shingles vaccine at no cost to them, they're not going to go to the pharmacy and get it. And it's been very important for us also that we are constantly partnering on the implementation side, so that information is getting out so that people can actually take advantage of the changes that are occurring as well.
Well, I think that goes nicely into the next question, which you're already talking about a broader vision and how it's going to be all hands on deck. But, CMS has a 5-part strategic vision for the agency. Can you talk a bit about how the IRA fits within this vision, and how you hope to see kind of that connectivity throughout the next few years?
Absolutely. So I published a piece now more than a year ago on kind of the vision for Medicare. looking at how we can leverage the Medicare program to advance health equity, to expand access to coverage and care, to drive innovation for more whole person, high quality care, and to promote the affordability and sustainability of the Medicare program for future generations. And implementation of the IRA, we really think about it across all of those goals, right? When we're talking about looking at unmet need, looking at the impact of a drug for specific populations, that speaks to the heart of a lot of what we know about health equity. Real world evidence, coming back to what Rena said about, clinical trials having a certain clinical profile, there's also things to consider about how drugs are taken in the real world, in people's communities. Do they have family support? Are they on, polypharmacy that they're trying to keep track of things? Are they able to get to the pharmacy? There are all sorts of considerations like that now real world evidence enables us to better incorporate, which I think really strikes at some of the heart of how disparities otherwise can persist, and where we can start to take that into consideration as we're thinking about what innovations are out there. Access, I think we've talked about that, right? In terms of when we can reduce financial barriers and can really improve access for some of these medications. Innovation in whole person care comes right back to a lot of what we've been talking about. And, for sustainability, certainly, our ability to address price increases, to negotiate, to decrease out-of-pocket costs, all get to those issues of affordability and financial sustainability. And underneath all of it is really at the core, keeping the person that we're serving in the middle. And I think that's something that everybody who works in healthcare, ultimately you go into healthcare because you want to help people. And so how do we make sure that we're keeping people in the center of that? And how do we make sure that we're engaging everybody in the ecosystem who is trying to help that person? And that also has been, I think, a very exciting opportunity in implementing the IRA, that we really are generating conversations across various sectors. And, at least for me, where I sit, where I get to speak with patient groups and with providers and with manufacturers and say, okay, what's working well that we should say, pour some hot sauce on, or chutney since I'm Indian, and really expand. Where are there areas for improvement that what we're doing now in implementation can really try to address some of those gaps and improve? It really presents a wonderful opportunity as we are coming out of the pandemic, thinking about healthcare more broadly than perhaps we were before.
And maybe for the both of you, just what are some other areas that we should be incentivizing? We talked a bit about, is there an intersection with drug pricing and contracts and, within IRA? Do you see kind of future considerations with these types of contracts within this kind of drug pricing negotiations or Part D redesign?
I'll pick three the areas I think that are really interesting for us to be paying attention to. One is the leveraging of technology to identify patients early on in their journey to be able to link them to care. And then when we link them to care tied to value-based benefit designs. It doesn't help a patient when we link a patient to care, identify a therapy that they could use in order to solve the issues that they are facing, only for that drug to be placed in tier number 5, 6, or 7. And they have to run through all kinds of hurdles and hoops in order to get access to that medicine. I think that's an area that we can begin to move to a better place. I would say the second piece is furthering outcomes-based agreements with payers. So often I've been on the other side of the table negotiating a deal with a health plan. And what we find is there is good intention up front to go down the path of an outcomes-based agreement, and then things get stuck in the mud when we are discussing the data, where to pull the data from, the fact that the patient won't be in that health plan in 3 years. So how are we going to understand the longitudinal the aspect of their care? And before you know it, between discussions of surrogate endpoints and hard outcomes, we end up back devolving into a regular type of a rebate agreement, which is not really where the field should stay. And I think we should continue to move. And I'm hopeful that we can go in that direction. And then the last piece I'll mention are the financing opportunities. You know, our financing of these high cost new therapies that are the curative in some of the cases has not kept up with the evolution in the scientific realm. And I think we are now at a place where we can reimagine what financing could look like based on how it's worked in other types of industries. And so you can think about things like a Netflix or a subscription type of an approach, a based approach. You can think about a population approach to funding the care. You can start to think about the warranties as well. And I think there are many such new models that are currently being discussed and talked about. And my hope is that companies and products that are part of such arrangements will be able to generate real world evidence that ultimately will help them when that product is up for negotiation with CMS. And I think that we can build in those types of incentives as well as this law continues to progress.
I swear that Moon and I did not coordinate this. So I think that we need to get real on innovation and what is valuable innovation. We have drugs that are truly curative and that are available now. And we need to ensure that people are actually getting access to them. We also need to ensure that the industry understands that when they bring the next cure for HIV, we're going to pay for it. And that we're going to make sure not only that we pay for it, but that people actually get access to them. So I'm excited about a couple of different initiatives. The first is that we need innovation in payment methods. Doctors only do what they get paid for. Sorry, I'm a little cynical as an economist, but there are efforts that are being rolled out now to ensure that we can connect doctors and hospitals to motivate them to go out and diagnose these diseases that have very significant diagnosis and treatment. A great example of this is the national hepatitis C model. We think that there's going to be a PrEP national model as well. Fantastic, because that's linking doctor goals in the community to diagnose and treat their patients with innovative payment methods to go out to pay them and also pay the innovators. On innovative payment models, I also think that there is a place for subscription models and also for outcomes-based payments. You don't need a subscription, you don't need an outcome-based payment if a thing works. We only need them when it's too expensive to pay unit price. So subscription models help lower the unit price so that but they're part of a larger mission to support public health. On the other side of this are outcomes-based contracts. And those we need because we don't actually know how good this product is. And we need actually real world evidence to go out and tell us how good this product is in the local community, in the patient populations that are real, not clinical trials based. So the CMMI model for sickle cell disease and some other gene therapies, I think is a super exciting next step. And then lastly, I think we still need innovation in products. There's a substantial amount of unmet need. A great example here are point of care testing for hepatitis C, for example. New antibiotics to treat infections that are where we're finding there's resistance already. Syphilis is a good example of that, where we do need to signal to the industry, hey, if you bring new products to market, if you bring antibiotics to market that really are meeting unmet need, we're going to pay for them. Even if at the end of the day, we may not use them and we may stockpile them. So finding innovative ways to push and pull the products that we need that are both drugs, but other things as well, I think is the next frontier.
Thank you. So with our last moments, I would like to just ask Rina and Muna. I mean, we said before, this is a big deal. This is a big legislation.
Mina has a lot ahead on her plate. But you know, what's one suggestion, recommendation that you have for CMS as they implement the IRA legislation? And then last word, Mina, you know, what's one suggestion or recommendation that you have for us as a field that would help your agency as you kind of embark on the next stage of this implementation?
I think the thing that I'm most concerned about is competition. That at the end of the day, our system works because we pull new products into existence, we pay for them, and then they face competition. If there are parts of these policies that might frustrate even further competition, then that is a place where there should be focus by policymakers and focus by agencies and focus by our community. Thank you. Thank you.
And I would just add to that, just because we all care about the innovation and the fact that we want to keep the United States the leader in innovation in the world. As we go through this in this very short time frame, we are trying to figure out how to implement the IRA. Until we have a framework that's fleshed out, I think the industry would welcome the opportunity to be able to understand that if the MFP can be at the highest price it has been set based on the time in the market, it will give the industry the clarity and the predictability that right now it needs as it continues to bring forward innovations that save and improve lives around the world. Thank you.
I would say it's so important to have engagement, you know, where people have ideas, suggestions, thoughts, as concrete as possible, to be able to provide them to us. And similarly, when we are putting out policy, to partner with us to make sure that it is taking life on the ground. I cannot emphasize enough how important it is to all of us to be able to engage in these dialogues, to hear people's ideas, to understand the different perspectives, because ultimately our goal is to implement this law in the most thoughtful way possible so that we can improve access to affordable and innovative therapies.
Great. Thank you. And please join me in thanking this.
Well, we have a tough act to follow in that we are coming off the break. And so hopefully we are so exciting that we are going to draw people in with their coffee and cookies to come talk about workforce. So we've been talking about a lot of really important topics for the last couple hours. You know, we've talked about new biomedical innovations that can help reverse America's health challenges. We've talked about ways to improve public health and healthcare collaboration, especially in ways to help with pandemic preparedness. These are all great initiatives and they all depend on workforce. And let's be honest here, the healthcare workforce right now is not in a great place. It's been a rough couple of years. There's enormous amounts of burnout. There's enormous amounts of stress. We've really seen it being a very difficult working conditions in many ways. And frankly, we don't necessarily have enough healthcare workforce right now. And it's not easy to just simply will more healthcare workforce into existence. It takes years, sometimes more than a decade, to train many of our healthcare professionals, many of our physicians, nurses, and others. So it's a really challenging topic we have here, but we are very positive and solution-oriented here at the Margolis Center. And we've got a great panel today that's going to talk about, you know, what can we do on making healthcare workforce better? How can we make this situation more positive? So I'm going to give a one-sentence biography for each of the three panelists here, recognizing I'm not remotely doing this justice, but you've got much better biographies in the program. We'll start here on my left with Chris Chen, the eponymous CEO of ChenMed. And ChenMed has really done some really exciting work on advanced primary care, especially including accountability for total cost of care and outcomes, helping America's seniors get better primary care. To his left is LaShonda Collins, who holds very senior roles at Optum, really thinking about public health strategy, emergency preparedness, emergency response. Before her role at Optum, she held several executive level roles at the Army and a number of healthcare commands, really helping to improve healthcare there. And notably, she is a Duke alum with her DNP in nursing. And then to her left is Dr. Kristen Gertz, who's professor of orthopedic surgery at Duke, has an extensive research career, really thinking about different ways of delivering new models of care, especially for pain and spine-related disorders. So we're going to get into what, not only what are the challenges in the workforce, but what can we do about it? So let me start here on my left with Chris Chin. So Chris, we've got one of the problems we have is really we don't have enough workforce. Another challenge is we really haven't trained or prepared our workforce for new models of care. And you've done a lot of thinking. You've written a whole playbook, in fact, on new ways of thinking about primary care and primary care teams. What are you really seeing as a big challenges in helping provide the skills and capabilities that say primary care needs to succeed?
Well, Robert, first of all, let me do a shameless plug. The entire playbook for how we think about developing our quote unquote talent factory for primary care, we actually wrote it into a book, my brother and I, and we published it. So it's called The Calling. There's a ton of IP in it. It won a gold medal on the Global Book Award. So go and look it up and the answer's in there, but I'll paraphrase it really quickly. There's a shortage of primary care in this country. And people are struggling to fill vacancies. We don't struggle with that. In fact, we have a waiting list of primary care doctors that want to join us. In fact, we turned down, of the 4 doctors that want to join us, we turned down 3 of them. Okay? So how is that the case? And especially during a time where there's burnout. And I hear a lot about burnout. Burnout, I think, is a challenge because of 2 major issues. Okay, burnout is, do I enjoy the work that I'm doing? And do I feel like I'm making a difference? It's really about purpose and relevance, which every human being wants. And when you're missing those 2 things, you're going to have a high rate of burnout. People aren't going to enjoy what they're doing. Now, a lot of people think money is the leading thing. Just look at the studies. Money is not the leading reason for a lot of bad things happening at work. Right? Or your bad feelings about your work. So here's the reason why I think people are burning out. We are taught in school, this is back to that training piece, taught in school, then reinforced in residency, that the natural hierarchy in healthcare is hospitals on top, specialists and doctors are number 2. By the way, this is also the lobbying power in this country. And then primary care doctors at the very bottom of that hierarchy, okay? I guess, what are they, 3rd-class citizens at this point? They go to large systems and they're told they're a loss leader, and they're paid after volume, and their goal is to primarily increase the downstream utilization of other higher hierarchy things. That's basically how they think about their jobs. So they're burning out. At ChenMed, what we do is we said, this is the way you've been trained. So it takes us, we select very, very carefully. We psychologically profile our folks for 5 hours. We get a lot of data, and we decided these are the types of doctors that we think we can spend 6 to 9 months deprogramming a reactive and very myopic care approach to now practice in a way that's proactive, that is accountable for the outcomes and the patients and the cost of care. So they're no longer glorified triage. They actually are now from the bottom to the top. And it takes us 6 to 9 months to deprogram and then retrain that in a primary care doctor. Once we do that, we then create a career path, because think about what we're creating right now. We're creating preventative care. Value-based care, in the end of the day, is holistic preventative care, because that's how you save money, right? You lower hospitalization rates, that's a $30,000 cost. You can invest with primary care, and you do it holistically. Guess what? You can prevent that hospitalization, and if you can do it for $5,000, you save $25,000. So that becomes our model. And then technology, one last piece. Doctors hate technology. One of the reasons why they're burning out is because they're being forced to use an EMR system that's designed to increase revenues. They know it. Everybody knows it. In our environment, we said, Doc, we'd like you to create the technology. I've got a technology shop with 350 technologists. We pair doctors with their technology and say, help us create the future of value-based care. Come here, learn what we've learned, but then help us create that new future, and you get to create the workflows. that improve the outcomes of patients, not whatever drives the greatest revenue for billable amounts or everything else. What you think will drive to a higher outcome, which then will lower that cost. Yeah? And so because of that, that word has gone out. People are coming in. We're embedded in about 75 residency programs. We're giving lectures, teaching people about how we think. We've now published it in a book to say, if you're training, by the way, you should start thinking about primary care doctors in this way, not glorify triage, but being accountable for the total care of the patient and the total cost of the care of the patient. So moving the hierarchy, and that's all in the book of how we do that.
Great, thanks, Chris. LaShawn, I'm going to go to you next. So we've been talking again for the last few hours about ways to rethink preparedness in public health, and really some of the innovations we've talked about would be very helpful outside of an emergency. You know, for instance, during COVID, we saw a lot of innovations in moving care from the traditional facility-based approach to moving to home, having, say, hospital home programs, or having telehealth so that folks could get care when and how they needed it. I know you've done a lot of thinking about this because the workforce isn't quite there for a lot of these new care models. You know, how are you thinking about how the workforce can be trained, how it can be supported in delivering care in these new ways?
Yeah, Robert, thanks, first of all, for having me.
Of course.
Really excited to be here. And yeah, when you said Duke, you had me at hello. So I was already here. But you're absolutely right. What we recognized during COVID was, just by demand, people were not able to seek out care in traditional brick and mortar. And more, we had to take care to where people could access it, where they wanted to access it, and where they were comfortable accessing it. What we also saw was that those licensed credentialed providers, whether they be nurses, doctors, PAs, were needed in the brick and mortar hospitals to take care of those patients that were inpatients. And so when we were setting up and at OptumServe, we partnered with several states. We set up, sites for folks to come and receive, whether it was COVID testing, COVID vaccines, COVID test to treat, monkeypox test to treat. We set it up in communities where people could access it. But what we also recognized was there is a shortage of folks to deliver that care. One of the things that United Health Group, our parent organization, has done is established a program called an apprenticeship program. And so it really is recognizing what you need in that allied health professional space and creating it. In partnership with the Department of Labor, we are now training pharmacy techs, medical assistants, and community health workers to be able to go out and extend this. You talked about not having enough primary care providers. So we have to figure out how we extend those providers that we do have. And Dean Ramos, the Dean of the School of Nursing at Duke, has a phenomenal outlook on that. And how do we really reimagine the nurse-led interventions in healthcare? Being able to have nurses and other professionals work at the top of their scope, and then creating some of these allied professionals that we're talking about at UHG to then be able to do hub and spoke type concepts of care, whether that's in a mobile setting where you have a mobile health vehicle that goes out to, communities every second Thursday of the month. And Jane Doe knows that her provider is going to be that same person that's making that circuit. That's value-based care as well, because now you have that consistency. Hearing more and more rural healthcare losing, access to care, not having those providers, not having those facilities. And so I think that having these community health workers, having these created new roles, expanded roles, will help us to be able to provide those services. You also have to make sure that the competency and the level of excellence is there. And so not only are we creating these roles, but these folks are being trained in a didactic setting. They're being trained in our clinical sites, but then they're sitting for the national certifications. Our pass rates are well above many of the traditional programs that's training these pharmacy techs and medical assistants and community health workers. And so we're really excited, and we're continuing to scale this program. And so we're really proud of how we're giving back and helping to alleviate some of the challenges that we're seeing in this space.
That's great. And Christine Gertz, I'm going to turn to you next. A major population health challenge is really unmanaged pain, which has a huge human cost. It has an economic cost in keeping all the workforce, and it also can lead, when unmanaged, to opioid addiction over the long term. And so, you've done a lot of thinking on new models of care, new workforce that can be used to help with unmanaged pain. Can you talk a little bit about that?
Happy to do that, Rob. Really a pleasure to be with all of you this afternoon at this exciting conference. If I were going to do one thing to impact the healthcare workforce right now today, it would actually be to implement the American College of Physicians guideline for low back pain. And the reason for that is because what they recommend is that clinicians and patients consider non-pharmacological treatment, things like exercise and massage and acupuncture and spinal manipulation before considering prescription medications. So if in fact we were to implement that guideline widely, we would be looking at the workforce in a completely different way, because primary care physicians are, low back pain is one of the most common reasons why people see a primary care physician. And yet primary care physicians tell me they had between 7 and 9 hours of training in medical school to treat those particular patients. They have little in their toolbox in order to address this problem. However, we have a workforce out there already that is in fact well-trained to treat these patients. We have over 300,000 physical therapists and over 70,000 chiropractors who are in an excellent position to deliver guideline concordant care at the forefront of the patient experience. And we actually know that when patients do get that kind of guideline concordant care at the beginning of their care trajectory, they're less likely to transition from acute to chronic low back pain. So by what I'm proposing is that we repurpose an already existing workforce by leveraging providers that are in many ways best suited to care for patients with low back pain. And by doing so, not only will we help address the, well, I would argue that the opioid crisis is largely a low back pain crisis. We would be addressing that, that profound public health crisis that we have, but also we would be opening up an opportunity for our very burned out primary care physicians who to be able to really focus on those patients that they are best able to treat.
Thanks, Christine. And over the past few years, especially during the early phase of the COVID pandemic, but frankly, throughout time, we've seen both exacerbations, but also really exposure of long-running healthcare disparities. And one way to address that is to start to change some of the workforce that we use, pulling in people from the community. LaShonda, you mentioned community health workers are a really helpful way to bring in folks who understand the people's actual needs, but also connect to social drivers of health and services that can help with those types of situations. So, how can we better integrate community health workers, other team members that really understand, how the local community is affected and can really be helpful in addressing many of these longstanding disparities? And maybe LaShonda, I'll start with you, but Chris, I have a sense that you're going to want to jump in here too.
So as we know, healthcare is local. And what we also know is that 1/5 of the counties that make up the United States are considered rural. When we look at the folks that are joining our military, I'm a veteran, I'm a retired Army nurse. And so when we start looking at what makes up our military, a lot of those folks are coming from rural America as well. We have enlisted service members, allied health professionals that serve as medics and corpsmen in uniform, and they deploy and they do miraculous things that save lives. But because they may only have a credential of a paramedic level B, when they come back, they don't have the licensure or the certification to be able to deliver care. And so how do we tap into that really untapped resource that now these service members are coming back, they're underemployed, many are unemployed, during COVID, when we were looking for folks to be able to help us with the testing and the vaccines, because they didn't have that level of licensure or credentials, we weren't able to use them. Many of them wanted to volunteer because they knew those communities, they lived and worked in those communities, and they wanted to take care of their loved ones and their families and friends. And so I think we've got to reimagine, we've got to be a little bit disruptive in the way that we do this. And we have to recognize that people want to receive care from folks that they know and that they trust and that they, go to the grocery store, church with, and watch their kids play sports. And I think we just got to get back to basics and be disruptive.
So we notice in every single zip code, in every single city in America today, there's a zip code in which a life expectancy is 10, 20, or even above years lower than a zip code in the exact same city, miles away. And so we said, okay, let's create a care model, take global full risk, lead it with primary care, and go straight into those neighborhoods. And here's what our patients look like, right? So roughly 70–80% of our patients are underrepresented minorities, average age 72, typically have between 5 and 6 major chronic conditions. So the old, the poor, and the sick. And then we had to find people that were willing to go into these neighborhoods that, by the way, many people were abandoning, right? We were seeing hospitals and nobody's opening up ambulatory centers in these neighborhoods, right? And so how do we convince people to go? So hence the psychologic, testing that we did. We were looking for mission-driven people that really wanted to make a difference, to go into these neighborhoods and fundamentally do what we have done in almost every single market, which is reduce hospitalization rates by 30 to 50%, stroke rates by 20%, all published on peer-reviewed journal articles, reduce these horrific complications from all, downstream diabetes and everything else. And we're doing this, and we're not trying, we're actually doing it. Guess what our workforce looks like? After all that psychological testing, after competency testing, we test the 3 C's: character, competency, and chemistry. The people who pass the character and the competency assessments, and they're great and they're living great results. It turns out our workforce is 70% women of color. I have no diversity goals. Okay. We literally just said, we're going to go find the best people that are mission driven, that are going to go into these neighborhoods and actually make a difference and be accountable for making those difference under a certain budget. And we were surprised to learn this is what our workforce looked like, because I had D&I people come in and study us, and because I wanted to see how we were doing. And I was like, yeah, we're not going to study that much more, right? So that should be shocking to most people. And it was not shocking to me, but it was shocking in the sense that, like, wow, this is what you get when you go into these neighborhoods and try to make a difference.
Okay. And so one of the points that we've talked about here, and we like talking about money sometimes, is that it's actually not about the money. And I think, Chris, you noted that early, that it's not actually just about the money. There's always money issue here, but there's other things that maybe are holding our workforce back. And I think we've talked about a variety of regulatory challenges. There's other challenges as well that are holding back this positive models that we've got available. Christine Gertz, I'm going to start with you on this one, because I think you've noted in a variety of settings, there's a number of things that are keeping the workforce models that you were talking about earlier from happening. And it's not only about payment. Can you talk about that a little bit? What are the top regulatory things that are keeping us from achieving this vision?
Well, I think payment is actually one of the key things that is keeping us from this vision, because there is such a misalignment right now between payment policy and best practices for low back pain. We are very well insured for things like spine surgery and corticosteroid injections and MRIs, and not very well covered at all when it comes to some of the things that are recommended by guidelines, such as yoga and Tai Chi, and even there are even serious impediments or barriers for payment. Things like physical therapy and chiropractic are often covered, but there are real limitations or barriers. But I think other barriers that exist are, first of all, people just don't even think about this. They don't think about, we have, our tendency is to do what we've always done. And so thinking about new models of care can get really difficult to wrap your head around, and change is hard. And so moving to different models it can also be difficult. But what I've learned is that if you have a champion, if you're able to go into a system, if you have at least one influential champion who is able to just start to pull the thread on how we might do things a little bit differently, that you can make real change happen in spite of significant barriers.
Chris, do you want to jump in here?
Yeah, when I say money is not the number one reason, or not even, in my opinion, a top reason why, a doctor would choose to work in one place or the other. But I do think that payment reform and how we pay for care is really, really critical. Absolutely. A couple examples. So let me use low back pain, right? I'm a heart doctor by training. And I came out of my board exam years ago. And my dad is a doctor. And I said, hey, there was this question that asked me what % of low back pain resolves with conservative management. It was on my board, right? And the answer is, of course, 95% within 6 weeks, right? That's the data that supports it. I don't know if there's something new. My dad said to me, who took the board exam like 30 years before that, or 25 years, because I had the same question, right? And so first of all, they're asking that question because they want people to know it. And they've been asking that same question for the last now 40 years. And guess what? Has there been any change? Let me give you another metric just to show you. When I was doing my training, all these studies came out that cardiac caths do not improve in elective settings, do not improve symptoms, death rates, or a risk of myocardial infarction, which is a heart attack. So since all of those studies have come out, and I don't know, small journals like the New England Journal, Lancet, things like that, what has happened to how often are we doing these procedures? No change. So, and that's because you have an incentive to not follow the guidelines. Do you know why nobody's establishing ACP? It doesn't make money. It makes money to do spine surgeries. So I do think there needs to be that payment reform so we can align incentives to follow the right guidelines in a global risk, dual-sided environment, upside and downside. Boy, oh boy, do we follow those ACP guidelines? Actually, we have our version of it. Every one of our centers has acupuncture. Every one of them, included as a part of primary care, as an example, in Tai Chi classes and all these other things. So boy, oh boy, not only do we follow them, but we take it to the umpteenth level. Why? Because we're at global risk and we can, and our payment model through Medicare Advantage allows us to create what we think is best for the patient, not what's best in terms of billable revenue.
And Robert, just, one other thing, when we start talking about, non-dollar impacts, I think what we recognized during COVID was the increase of states that adopted the Nurse Compact Act. And so, in 2017, we were really restricted as to how many states would allow nurses to practice across state lines, that if they didn't have a license in that state. And so what we saw with the mass demands of hospitals that were being overwhelmed and having to bring nurses in across state lines, we had an increase of 11 states that from 2017 to 2022 that joined the Nurse Compact Act. And that really helped to bring some relief and also move from some of those states that had started to gain some traction with improvements in COVID to some of those that were still considered red. And I think that was one of the big things, big improvements outside of dollars that I think we've done over the COVID pandemic that helped us tremendously.
And I see we're getting short on time, so I'm going to ask maybe one more question here, and then do some wrap ups. So actually, Sonia, you teed this up nicely. There have been a number of flexibilities over the course of the acute phase of the public health emergency. In terms of practicing across state lines, in terms of telehealth, home-based medical care. Many of which of these flexibilities are due to be phased out. From your all's expert opinion, what are the most important flexibilities that we want to keep going for in the hopefully sort of after the acute phase of public health emergency, and where should we really push policy going forward? And so, Sonia, do you want to start with this one? Your top priority?
So I think the top priority is that, in many instances, we saw some of the competitiveness between, I'm going to call them guilds, that went down and allowed folks to be able to practice, right? And so you had with the public health emergency authorizations where, we were allowing different professions to administer vaccines or allowing different people to do different things and just providing maybe a little bit additional training or tweaking or so I think we've got to continue down that path. We've got to figure out how we drop the guilds. And I know there's always going to be that nurse physician and what should the nurse be doing? What should the physician be doing? But recognizing, as we said earlier, there is such a limited number of primary care physicians across the United States. How do we take the PAs? How do we take the nurse practitioners? Again, allow them to practice at the top of their scope, not only, the advanced practice, but also how do we take those registered nurses, tweak it? This is that nurse-led paradigm shift that Dean Ramos is talking about. How do you take that and equip those registered nurses to be able to go out into those spaces where there aren't enough primary care physicians to provide that basic primary care? We have the telehealth, we have the reach back, that if there is something that is outside that scope of practice for them, they can reach back and get additional assistance. I think, we're going to have to continue down those paths. And then also, how do we have people incorporate more of technology into the way that they are comfortable receiving care? Not many people in small America. I'm from Vidalia, Georgia, very, very small area. And so when we start talking about technology, utilizing AI, utilizing all of these things are coming about, how do we make that, make the system work better for everybody?
Great. And we have 1 minute left. So in the final minute, I'm going to ask each of our three panelists, what is their top recommendation? So if you're a CEO of a struggling, say, rural hospital, or that you are a head of a primary care clinic, or you are out there and delivering healthcare every day in mobile settings, what is your one workforce recommendation that you really want folks to think about? And maybe Christine Gertz, I'll start with you.
Implement the American College of Physician guidelines for low back pain.
I like being consistent. Shonda, what would you add?
Invest in your people.
Absolutely. And Christian?
I want to double click on what you're saying, really. You have to give people a sense of hope. And the problem is, if you're running a small rural clinic, that challenge, given this existing ecosystem, is more difficult, right? And so find ways to just show people, hey, we're on a path that's going to improve the system rather than consolidating and raising prices. Everybody knows what's going on. Your workforce knows what's going on. They don't want to be a part of that. But if you can show them a path to saying, we want to be a part of something that moves things in a positive direction, where we're going to give better outcomes to Americans at a lower cost, as opposed to what we've been doing, which is lower outcomes at a higher cost, which your workforce knows, you're much more likely to attract people. You're much more likely to retain people. They will feel purpose. And that's why they entered the field in the first place. And that would be my recommendation. Give them purpose.
And that is a positive note to end on. Let's thank our panelists here. We'll move to the next session.
Please welcome back to the stage, Dr. Mark McClellan.
Very much. Thank you. A great discussion, and I want to thank all of you who've been with us throughout the day, both here in the room and online. We're now moving to our last panel, and I'd like to ask Adam Bowler to come up and join me on stage. Adam is the founder, CEO of Rubicon Partners, and I'd also like you all to welcome two of our virtual participants today. Liz Fowler is director of the Center for Medicare and Medicaid Innovation, and also deputy administrator at CMS. And then Andy Slavitt, joining us online as well, is founder and the general partner of Town Hall Ventures. Liz is actually local, but Liz, I think you're doing your part for American public health by getting over a respiratory infection and doing us the favor of not spreading any contagion. Hope you're feeling a little bit better. Andy, that looks like sunny Southern California. I don't feel sorry for you, but thank you for being thank you all for being with us today. And I guess another way of describing this group is as a CMS Alumni Association. I think all four of us, including Liz, this is your second public service stint there, I think, Liz. So third. So just for those of you who don't believe in public service. But we have a lot to cover in this session around accelerating value-based and accountable care and what are the challenges, what's working and what's not. This discussion comes at the end of an afternoon where we've heard a lot about some of the major challenges facing our nation's healthcare system, and even more importantly, our population's health. That includes the workforce and burnout issues that we just talked about on the last panel. It also includes helping to align what healthcare professionals who are working so hard are doing to support more progress on population health and health equity. It includes affordability. It includes bringing pharmaceuticals, including those that have not yet been fully developed, into more advanced use and broad base in the population. And that aligns with the CMS goals that Mina Seshamani mentioned earlier, and that we're hopefully going to talk about more now. So Liz, I'd like to start with you. Mina alluded to kind of a shared vision that CMS leadership has laid out, and that I think is similar, Adam, to vision that you had before, and Andy, dating back to your time, and the Biden administration, I'm sorry, the Obama administration as well, around giving all people in Medicare access to longitudinal, coordinated, comprehensive care. What we've talked about here today along the lines of accountable care. And Liz, I'm wondering if you could talk a bit more about that vision, why you and the other leaders at CMS and many of your colleagues and public-private effort that I work with, the Healthcare Payment Learning and Action Network, why all of these efforts are viewing this change in care and some of the changes in payment and everything else that goes along with it is so important.
Sure. And first, let me start by thanking.
Oh, you don't sound 100% yet.
Yeah, I know.
You can keep your answers short.
Well, and this is why I'm not there in person. I'm getting over laryngitis, obviously. But thanks a lot for the invitation to be here and be on this illustrious panel with my colleagues, Mark, Andy, and Adam. It's always nice to be sharing a stage with you. And the previous discussions have been really rich and illuminating, and addressed some of the most important challenges facing our health system. In terms of accountable care and what that means, I think if we asked everyone in this room what it means, we might end up with a different answer. And so maybe start with how I think about the definition of accountable care. And this is on the CMMI website. It probably came from Adam at some point. But so navigating the health system is really complex and difficult for anyone, and particularly for beneficiaries with multiple chronic conditions who receive care from more than one physician or in different specialties. And we've seen over the last 20 years that fragmentation in healthcare for Medicare beneficiaries has increased exponentially. Just over the last 2 decades, the percent of beneficiaries seeing 5 or more physicians each year nearly doubled. And we've seen an 83% increase in the number of specialists that a primary care provider needs to coordinate with on behalf of their patients. And this means that Medicare beneficiaries have multiple providers, duplicative and unnecessary services, potential out-of-pocket costs, implications for each service, and no single provider who's coordinating their care or accountable for their overall quality of care provided. Today's fee-for-service system, and I think the last panel touched on this, doesn't really provide the mechanism or the means to effectively facilitate care coordination. In fact, the payment system works against these efforts. And so this is where accountable care plays a role. And the Innovation Center, again, credit here to everyone who came before me, defines accountable care as a doctor or group of healthcare providers or hospitals taking responsibility for improving quality of care, care coordination, and health outcomes for a defined group of patients, thereby reducing fragmentation and unnecessary costs for patients and the health system. And these relationships improve patients' qualities in the following ways: reducing the likelihood they'll get repeat medical tests or unnecessary services, incentivizing doctors and health professionals to consider a patient's entire health history, enabling ACOs and advanced primary care practices to deliver team-based care that focus on beneficiaries with the highest needs. So providers can spend more time with patients who need it and less time on billing and administrative tasks, and then increasing communication and collaboration across different settings and professionals. And I think the rationale is, in short, is to improve the healthcare experience for patients and the delivery system for providers and the Medicare program by reforming the fee-for-service volume-based incentives that have really underpinned our system for more than half a century. As you said, we aim to have every Medicare beneficiary and the vast majority of Medicaid beneficiaries in an accountable care relationship by 2030. And we can meet this goal by being as clear as possible about where we're heading, working closely with our colleagues across CMS. And for CMMI, that means working closely with Mina and her colleagues that run the shared savings program, and then continuing to focus on policies that will advance this goal.
Thanks, Liz, for that a pretty comprehensive overview despite the laryngitis. I'd like to turn to Adam and Andy now. You all led respectively the Innovation Center and a lot of policy initiatives at CMS and CMS itself during the Trump and Obama administrations. The goals that Liz has talked about are ones that to succeed, we're talking about 2030, but some interim progress along the way are ones that are going to have to outlast an administration, and presumably as well have better support if they outlast or not just associated with one particular party. How likely are these CMS goals to continue and to provide, I think, probably the certainty that a lot of healthcare providers need to make the investments and the supports and the other changes to get from where we are now, which is still in many respects a long way from what Liz just described. Adam, do you want to start?
I have a few thoughts. One, I always think someone invited me and Bob Kocher, and I'm sure you guys know Bob, who worked in the Obama administration. And I always think it's interesting because they think there might be some like interesting counterpoint. I'm always like, it's going to be a little boring because we're going to align. And I think part of the reason is when you look at innovation's mission and what we're talking about today, lowering cost of care and improving quality for Americans is that's not a Democrat ideal, it's not a Republican ideal, it's an American ideal. And there are things that people can agree on, and we do here. And so that's a thought. The second thought I have is when I can't remember if I had accepted but hadn't started or where I was in the CMMI process, but Andy and Patrick, who I hugely talked to before doing this, they said, what are your thoughts on how do we approach this? Maybe it was at CMMI. How do we approach this so that it's not dependent on an individual that leads it one way or the other? Because it is an agency that could be politicized one way or the other. I don't totally know the answer other than, number one, we've been lucky. We've been lucky in how it was established. Patrick, administrator like Andy, administrator like Seema, current administrator, Chiquita, Liz, we've been lucky that people have used this and not lost track of the power of CMMI to make a difference in a really great way. And I think that was some of the underpinning. It's one reason why I know, Andy, ACA, CMMI isn't always associated because there are things that are political rights. This shouldn't be one. And so I think, one, we've been lucky. And two, part of it is the ideal that it represents that is hard to argue with. And it is an issue, and it's our best solution from a policy perspective.
Thanks, Adam. Andy? And you're on mute.
Let's start with where we know we agree. And it's a very important pillar that I think people are increasingly questioning, which is we need CMMI. And we need CMMI to be protected from being a political football. And I know that the four of us all agree with that. And the reason is, you know, people can be critical of any one specific model. And I think we would all argue you should be critical of the elements of models coming out of CMMI that don't work. That's how Liz and team are going to make them better. But it's different to say I don't like a particular model or don't like a particular benchmark or something, and saying that we would be able to get anywhere without an active policymaking body that can work and collaborate and importantly iterate and improve these models as they go along by listening. Without CMMI, the way policy would get done is largely through Congress. That's how models would get done. And imagine the lobbying and the politics and the lack of knowledge, quite frankly, that exists if you were going to do that. So I'm going to give a shout out to Mara McDermott, who I think is probably there, and to you, Mark, who is the policy chair of a new organization called Accountable for Health, which is set up to do exactly that, figure out how to invest in and educate people on why this matters. And it matters, value-based care matters, not the words, but the idea, because if you ask most Americans where they want the accountability for their health care decisions to be made, they would say in large numbers it's between them and their medical team, not an insurance company. So what Adam talks about, moving risk to the care providers and moving accountability to care providers, that's exactly what he's talking about, which is that people want to be able to meet with the people who are caring for them, who know their history, who know them the best, and who have every incentive to make sure that they get the right and best care. And the thing we also know is that once someone has a regular source of care for 4 or 5 years, their health improves and the cost to take care of them go down. That's what connection to the system is. Ask yourself if you would like your mother or father to have a Chris Chen. Like, what if Chris Chen was your mother or father's doctor and was there for all of their needs? And Chris Chen knew your parent extremely well, having 5 or more years of history with them. You'd feel pretty good about that versus what you probably have today for seniors. So Liz's vision is exactly the right one. It is the capstone goal. And I think it's one we can all get behind.
I do want to build on these comments by going a bit deeper into how to get there and some of the concerns, criticisms, et cetera, that have been raised in making progress towards these care models. So Liz laid out the vision. Andy, you and Adam reinforced why people might find that to be a better approach to care. And you mentioned Accountable Health and other organizations that are trying to help communicate that. But among the issues that have come up are that this is a different way of delivering care that requires some new kinds of investments to get there. We heard about the workforce restructuring to address burnout and shortages in our healthcare system right now. In the last panel, we talked earlier today about the supports that clinicians and teams of providers might need to help get out in the community, engage with people who are often left behind and who don't get to take advantage of the diagnostics and therapeutics and better specialized interventions that are available to help head off disease complications and avoidable costs. But that does mean investment. And there have been some criticisms of some of the CMMI models around steps towards privatization, essentially, that these are CMMI operates in a public program, the traditional Medicare part, not the Medicare Advantage part, and we get to that part in a minute, but that is intended to be more of a publicly overseen, publicly guided program. But a lot of these organizations are getting help from private investment sources and for-profit entities. And maybe, Andy, if I could go back to you on this one, thoughts about that and how to think about the role of the private sector in supporting this shift to accountable care?
Look, I mean, all of us wrestle, if you've ever been a policymaker, and I know that Adam has and Liz has, with with profits and how profits can be sometimes made to be more important for people than patient care. And as policymakers, we need to put in place good policies that watch for that. It is absolutely concerning and something to watch for. I don't think that's what we're talking about here, though. Largely, I think what we're talking about is a way of paying people and a way of giving people resources, technology and other types of resource that allow them to take care of the patients the way they want to take care of them. And I would make the case that even if you had a completely public system, if you had a single payer or something like it, you would still want to have a value-based care system, value-based care models, and how you pay providers. In other words, where the money comes from, taxpayers versus employers versus beneficiaries, et cetera. That is one question, and an important question, and it's topic of debate. And as Adam said, I think the parties have more disagreements than agreements on some of that. But this is a different question. The question we're focusing on here is, how do you pay and support care providers so that they can create the best longitudinal relationship with an individual? And to me, that's a question you have to answer no matter the source of funds. So I think it is misleading and confusing to suggest that what the work we're talking about here is one that is about the private sector or the public sector. It is about care delivery, and it is about the better and best forms of removing obstacles to good care in an iterative fashion.
Yeah, we do have in Medicare and Medicaid, for that matter, public oversight, public financing, but largely private delivery. But that brings me to another criticism here, which is, even if you accept the point that investment is needed and it can help providers do a better job, I think there are a lot of providers out there who feel like they're kind of being left behind in these efforts. Maybe there are some primary care groups like Chris's that have done really well, but maybe especially if you're not a primary care provider, if you're a specialist, is accountable care really turning out to be around helping you be part of a new way of delivering care that focuses on population health and improving outcomes and lowering costs? Or is it just shifting things around, just being a kind of tool that's being used to refer more patients to certain providers in a narrow network rather than really building out care capabilities? I know, Adam, your organizations do a lot to try to support better care capabilities. Appreciate your thoughts on that. And then I go back to Liz.
I have two thoughts. One relative to the first question, which is focusing on the answer in my mind, which is lower costs and higher quality, which to me can be done very well and in a great fashion, whether you're for-profit or nonprofit. And there's examples of wonderful for-profits and wonderful nonprofits, and some really crappy for-profits and nonprofits. And I do think one should look at that. I mean, people also ask too, you think about incentives, fee for service, or capitation or risk, and is there incentive to shunt care or to in general? No, but could that happen? Yes, that's what we need to watch to make sure. So I would say nothing's perfect, and those are the guidelines and the things you need to look out for. I think that in terms of specialists, in terms of, I do think, and also populations where it's harder to find primary care that's enabled, maybe a rural population, maybe in smaller areas. I think there is an argument for more investment in those areas if you're going to make a big difference. I think on the specialty side, there is the opportunity. First, we have broad primary care. There are longitudinal specialties like nephrology in the models that CMMI has, but that you can expand out to expanding out oncology as they've done, cardiology, other things that are longitudinal programs. And then in Medicaid, pediatrics, other things that you can do. And these are where CMI has tested things. And I think now we can come up with schema that fit well into a primary care landscape that are simple, and that measure. And then there are episodic specialties. So I hope where we eventually reach is a couple goals. One is improving quality for patients and lowering costs. That's real and not arbitrage. And number two, a system that in some ways, and this is the most challenging thing, is somewhat simple, not too complicated. Let's keep in mind, fee for service is not simple either. It's just that they're doing a lot. It's super complicated. So neither is going to be easy. There's no easy answers in life on things that are important. But as simple as possible, but democratizes and allows, if you're an ophthalmologist, there's a chance for you to think about this. And instead of separating out when you're doing two eyes, doing it at the same time, because that's better anyway, and I'm not optimizing for that. So some level of democratization of that over time.
Thanks, Adam. And Liz, I know you've similarly thought a lot about how these programs can reach more diverse range of providers and rural communities, as Adam was just talking about, and specialists that are an absolutely critical part of valuable, effective healthcare.
Yeah, and let me just say to the criticism about accountable care and moving the program towards privatization. I mean, in my view, accountable care, team-based care that puts patients first, is an approach that's meant to improve traditional Medicare. It's meant to bring some of those benefits of coordinated care and potentially extra benefits that you might expect from Medicare Advantage, but without the features that frustrate patients, like aggressive prior authorization requirements. So we hope the goal is that beneficiaries aligned to advanced primary care practices or to an ACO can see those benefits. And of course, they can see any doctor and any specialist they want without any restriction. So want to make sure that point is made. And just to the point about the role of the private sector, I agree. We think that private sector can have an impact on driving change, spurring innovation and disruption. But any positive can have a negative side, and we want to make sure that new entrants into the program, model participants they're there for the right reasons, with good intentions and with beneficiaries' best interests in mind. Sometimes we've seen in some cases what can be described as, maybe more predatory behavior. And we want to make sure that that's not what's coming into our model, that people are really there for the right reasons. And this gets at some of the criticisms that we've seen in ACO REACH, which is why we really tried to look under the hood. And when we evaluated new applicants last year for the 1/1/23 start, we looked really closely at leadership, governance, investors, and owners. And did they have a history of serving Medicare patients, experience in value-based care, a track record of success, any experience serving underserved beneficiaries, and really tried to focus on sort of getting the best of the best. And that, I think you also raised the point about trying to get safety net providers into models. And it's true that they've faced barriers to participating in value-based care and CMMI models. And in part, that's been due to a lack of resources. So to meet our goal, we really have to bring safety net providers into value-based care, and we have to create those multiple pathways for providers to come into these arrangements. And we're giving that a lot of thought. And I think you'll see some of that. You saw some of that reflected in ACO REACH. And I think you'll see some of that reflected in the next model we roll out on the new primary care model that really has a separate track that's aimed at FQHCs and community health centers.
Interesting. We'll look forward to that too. It's a critical part of delivering care, especially as we talked about earlier, with some of the gaps that public health in the United States has had to pick up for people with limited coverage or problems that are not dealt with well in many of our usual sources of care in this country. I want to switch gears to the Medicare Advantage side. So Liz, you may be a little bit off the hook for this one, at least with your the main part of your current job, but the other way to get to accountable care that CMS has emphasized, besides models like ACO REACH and the Medicare Shared Savings Program that Mina Sesamani alluded to earlier, is on the Medicare Advantage side. And that's now half of the Medicare program, its payments are at the person level. They're risk adjusted based on the expected health conditions an individual faces. And while there's a lot of evidence of adoption of alternative payment models that address the kind of goals that we've talked about today, including in Chris Chen's program, a lot of evidence of their success in Medicare Advantage. There's also been some pretty consistent and growing reports of higher cost to Medicare associated with the MA program, even to the extent it's delivering maybe more coordinated care, more programs like ChenMed, but also lower out-of-pocket costs of beneficiaries. It's still costing taxpayers more. And I have to say that risk adjustment system that's used in Medicare Advantage today is essentially the ones, and I'm dating myself, that we put in place back at the beginning of the Medicare Advantage program and Medicare Part D, where we didn't have electronic records widely adopted. We didn't have a lot of clinical infrastructure in place, like you all have emphasized is so important, data infrastructure and supports to deliver better care and support team-based approaches to care delivery. We had claims and we had data on costs and fee for service. And I have to say, if you had told me then that we'd still be using the same basic system for risk adjustment today, when now half the program isn't in traditional fee-for-service Medicare, and those that are in traditional Medicare are increasingly in these more coordinated, accountable programs, and that the payments would be based on costs in fee-for-service practice, not these better models of care that you all were alluding to, that the payment reforms, the accountable care makes possible. I have to say I'd be pretty surprised. So CMS took some steps to try to address some of these challenges with risk adjustment. I think they did sort of like, in policymaking, if you kind of ticked off people on, I should say, ticked off people on both sides a little bit. Maybe you've got good policy, but it doesn't seem like we're in a sustainable place in terms of the right incentives and financial supports for the MA program. And appreciate maybe Andy, Adam, both of you, have any thoughts on where we go from here? I know there are a lot of people who are trying to make direct contracting work in traditional Medicare who worry that, gosh, it's just less attractive if the payment overall is higher in Medicare Advantage.
You want me to start?
Sure.
Yeah, I mean, look, Medicare Advantage is a program that I think everybody across the aisle recognizes as an important part of the landscape and a potential solution. I think seniors should have choice. They pay into this program. But I think there's a couple things we should take note of. One is that as Medicare Advantage grows as a percentage of total Medicare, and I think people on both sides of the aisle have estimated to me that by the end of the decade, it could reach 80% of the program. Gone will be the days of living off of its comparison to Medicare fee-for-service, and in will come the days when Medicare Advantage providers need to be accountable directly to the trust fund and directly to taxpayers. And so this is I think we're living through what people don't really recognize is the glory days where it's relatively easy to do well in Medicare Advantage but we should be using that time for it to be a teaching tool for it to transform healthcare. And we could end up at a point, or we may need to end up at a point where the program moves, forget risk adjusted, and moves to competitive bidding and changes that dynamic entirely. As it relates to risk adjustment, I think it's important to understand that risk adjustment is an important idea, because some patients are more expensive than others. There's nothing wrong with that idea. So we're not going to blame you entirely, Mark. Secondly, the reason that it pays more when people are sicker is because people are supposed to be incurring higher costs. So periodically, CMS has to do what they did this last year and take a look and say, are there places where people are getting paid more and not incurring higher costs? And in fact, if you're coding for people to say, for example, as severely malnourished, as happens in parts of Southern Florida quite frequently, but we're spending no money to solve that problem, then you might suggest that's an inappropriate payment and needs to be changed. And I think that's all CMS really did. And I don't think, and we have, record high levels of supplemental benefits, most of which go unused and most of which are recaptured by the payers. So they're kind of illusory. And I think payers make a lot of money, both on a hard dollar basis and on a profit margin basis. Some of these products are double digits or more. So, I think we have to be able to have these kinds of reform efforts, which I think are substantially good, done in a way that isn't controlled by the lobbyists and isn't become a big giant political fight. Because if we can't reform and improve these programs along the way, then it will make the changes much more high stakes. And what will happen will be that it will reach a breaking point. So I would encourage everybody involved in the program, when the CMS wants to have this conversation, to share data, get involved in the exchange, think about how these things work. But I think some of the early rhetoric about these changes was clearly overblown. That happens in Washington, but it doesn't necessarily do any good. And in fact, it points to some of the excesses of the program that I think we don't need. We want a healthy, sustainable Medicare Advantage program, and if you want that too, then you shouldn't want these kind of arbitrage opportunities any more than anybody else does.
Adam, is this a bipartisan issue? Thoughts you'd like to add?
I like how you took blame though. So it's not, you heard it here, right? It's Mark's fault. I think that it makes sense from a risk adjustment perspective, that reform in the area makes sense. And I will say, by the way, you're at a wonky conference when this is our main, right? Yeah. And it's a hot topic in healthcare. Okay, it is. We all know. But I do think there are solutions here, and the reason I think there are solutions is trying to think about a problem, right? So as Andy said, risk adjustment is important. You think about who's winning and losing I always think about like aligning of incentives. I will say that the people that are doing lots of documentation too, because it's spend a lot of money doing that. There is a spend doing it. And so again, I think there is, especially now, a way to be statistically quite accurate without having to touch every single person every year. And again, the way I would liken that is when you do a political poll, you don't speak to every single person that voted in the election, or like Nielsen TV ratings, or not every TV. There are ways to do this in a thoughtful way where you'd actually take out cost, which is just wasted cost from that perspective. So I think there are reasonable approaches to reform that maybe everybody wins a little bit on it from that perspective.
So we've talked about some of the ways, some of the concerns have been raised and ways to address those. What about accelerating progress? So far, most of what CMMI has done in terms of expanding onto a base model here, the shared savings program, have been through voluntary pilots that then get incorporated. That's been a process that's taken some time. It's also led to some questions about whether these pilot reforms really do save. And I know there are a lot of design issues involved there, but I think one basic one is that it's very hard to save much money in a voluntary program if only people are going to sign up, if they think they're going to do better, have a good chance of capturing a large share of savings there. Appreciate thoughts from Adam, Andy, both of you, and then Liz about is it time for more of a mandatory push in the direction of accountable care?
I'll give two quick thoughts. One way I think you can do it either. So there's two ways you can do it. When we scored savings of models that we released, we only allowed people to enter even on a voluntary basis if it basically guaranteed the government savings of money. So, when you do any model, the Office of the Actuary scores all scenarios. And in some of the models released, every single scenario reduced costs because it was definitional. The reason I like that is it's our job to reduce costs and improve quality. And the more that's definitional, the more you're going to be able to certify something and bring it to the permanent program. So that is a route, which is voluntary, but you only allow people to come in that case. The second route is mandatory models, and that is going to drive savings if it's set up that way. So I'm supportive if it's thoughtful, transparent, et cetera. But I think it is very critical. And I think CMMI has evolved different times. As I said, first, you kind of let everything blossom, see what happens, which was the beginning. People are critical that, oh, CMMI hasn't saved so much money in these things. Well, there was that first phase where that was necessary. Then I hope, we tried to drive a phase where we said, okay, let's consolidate, let's drive savings, let's simplify a little bit. I think Liz has stepped it up further from that perspective. And I think that there's both those tool sets in the toolkit, and I think they should be used.
Andy?
There's a couple of views here. One of which is if you're going to be critical of voluntary models, it would be that all a voluntary model does is it rewards people who are already performing well. And that, and by the way, that's not a bad thing. Reinforcing people who provide good care and efficient care and high quality care with better payments that more reflect that is a good thing. But if you believe that what has to happen in value-based care is we have to give the tools for people who are providing care that is suboptimal, that by setting goals that will help them change. In voluntary models, you could argue that not only is it not happening, but it may be in some of these models that there are people who aren't even aiming to make it happen. They just go and form an ACO by looking at the data and finding people who are performing well, don't have them change a thing and just collect bonuses. So if your point of view on the theory of change here and where we are in the theory of change is that we have to find ways for people, like when we introduced DRGs and other things, to say, hey, we have to actually operate differently, then you'd be in favor of mandatory models. Now, Congress may not like it so much, and the political pushback is likely to be higher. And I think you got to take great care in those programs. But if you can do that and do that carefully, then I think it really is a path where you're going to get much more change much more rapidly. And so I think we should be having those dialogues and pushing the envelope. But most importantly, what does Liz think?
Liz, I know you're past the 1,000 flowers blooming stage and really trying to build out a core model for all beneficiaries.
Yeah, we are. And we laid out a specialty strategy last year when we released the 1-year update on the strategy, the strategy refresh, and talked about mandatory models as playing a role, but really having to be integrated into ACOs. And so not doing it willy-nilly, it's not any episode, but really thinking about how we can use them to drive more integration with primary care. If we do anything down this road, and I would like to, it's going to be very thoughtful, as Adam said. It's going to be, with plenty of chance for input, with public input. We're looking at putting out a request for information later this summer to get input that would help inform a potential strategy on episodes that will integrate with ACOs. So that's the first thing. Second, I'll just make the point that, yes, I expect that some won't like it, but I can tell you the experience from moving from a voluntary hip and knee replacement to a mandatory model is that some people got dropped out of the model when we went to mandatory and really wanted to stay in. And some of the feedback we've heard from providers is that they think this is the way we need to go if we want to move further and faster. And hopefully there's the tools and the resources and the timing that will allow them to do that. I know we're still in a difficult post-COVID period where, all the workforce issues that came up are very real. But this is a long-range strategy, and we want to give as much notice as possible. And that's the other thing I want to talk about just a little bit, and this gets to some of what Adam was talking about is, this definition of success for the Innovation Center is a very high bar. This sort of certification is on a net savings basis, which means any incentives you pay out counts against you at the end of the model. And it's really hard to make those numbers work. And so we're really thinking about, can we also put just as much emphasis on the quality improvement? I mean, what if we really did change the care experience and improve the quality of care for beneficiaries? In the statute, that counts just as much as savings, as long as we're not increasing savings. So we're really thinking about success differently. I think anyone who was part of the CMS Quality Conference a couple of weeks ago, there was a whole panel that highlighted this initiative we've undertaken called the Health System Transformation Initiative. We are really looking back across the evaluations and the learning systems from all our models. What are those sort of key themes and strategies? What did we learn that were it didn't matter which model it was, but we know that led to success and led to transforming care. And so I think we're hoping to put more of that out there. I think part 2 of it is really thinking about how do we design future models to capitalize on what works in terms of transformation. So I think really trying to do things differently. And so it's not just about the cost savings. I mean, if you think about all the areas in our health system that are underfunded, we talked about public health today, about primary care, about all these underserved communities. If the bar is savings, I mean, rural healthcare, for example, if you're aiming for savings in rural healthcare, you're never going to have a model that's successful. And we saw that with the chart model where we couldn't get rural providers in because that's not a viable solution for them. So more to come on this, but just highlighting that, number 1, we are looking down this road of mandatory, and number 2, we are sort of thinking about what makes a model successful and how we really transform the health system towards value.
Yeah, thanks, Liz, for talking about all this evolution and the move towards accountable care. And I'll give your voice a rest for a second, just to add that also a lot of initiatives at CMMI and CMS and working with other payers, with states, with commercial plans, with payer purchaser efforts around the country. So more predictability and more opportunities to align on a lot of these goals, since they're very important outside of Medicare and CMS programs as well. We only have a couple of minutes left. I wanted to leave maybe Adam and Andy with one hard question. So these are huge programs that matter more to people than probably anything else. And maybe that's why they're being left out of the debate we're having right now around debt limit. And that's sort of a short-term indicator of concerns that there are out there about the rising costs of federal entitlement programs and healthcare and what we're getting for it more generally. Do you have any final thoughts about how accountable care could be viewed as a more positive part of what the solution is forward? I know Medicare is off the table for these debates right now in Congress, but the usual way when there's budget shortfalls at the end of a year or something like that is to squeeze down the Medicare fee-for-service rates further, and that doesn't seem like a long-term solution. Is accountable care going to at some point be part of the vision for a path forward for our nation from a budget and overall federal sustainability standpoint?
Yeah, do you want me to take it? Do you want to take it, sir? Me? I think one of the interesting elements and one reason it doesn't play out at that level is that it's hard to understand for the average person. And I think, take something easier to understand, which is when people think about drug pricing and, what other countries pay versus this is a very easy thing for people to understand. And it tends to play out a lot more nationally because of that. And so it would be nice, I think, I've mentioned this time, and if I have things I wish I would have pushed on more to at CMI, if there's a way for individuals to participate. If their savings overall, they're part of a model and they get that ability, like a tax rebate, something like that. Again, I don't, what happens for people, I think, is healthcare is a longer term thing, unless it's closely and more relevant. Maybe that would make a difference. And people would see it more or would feel more real life and not as wonky, if that makes sense, even though it's really important.
Andy?
You know, there's a lot of ways that we could reduce costs if we had the political will and if we wanted to. And, you know, the CBO is rightly going to look askance at CMMI and say, wait a minute, you're saying spend more money here to take more money away here. And how do I know you're going to do it? And I know all the political pressures that come along with it, and it goes slow. And so it really isn't talked about in the same context as hard dollar savings. You know, the things that save money from a hard dollar basis are unit costs, and that's, you know, outstrips everything else by a large amount. And we have a very conflicted relationship with unit costs in this country. On the one hand, we all know they're way too high, not just drug prices, but, you know, emergency room department visits, et cetera. On the other hand, we're all sympathetic to the plight of local hospitals. We all are cognizant that we have a labor crisis, and by the way, we have 20 million people that work in the healthcare industry that don't want to see their pay cut or their jobs cut. So there's a lot of pressure from other places to keep costs high, and you know, making CMMI the one place that's supposed to be serious about costs, I think that misdefines that role. But I think many people would rightly say that if we want to have a serious conversation about budget consequences, it would be awfully nice if we could prove some things through CMMI, through Medicare Advantage, where we could say that's a way of doing things that works. A great example will be keeping people out of the hospital unnecessarily, allowing people to get patient in their care in their home or in outpatient settings, and to know that we have mechanisms and vehicles that work and do that, and that people like, because they don't want to be in the hospital when they don't need to be, and they want to be able to take care of themselves at home and want to be in a comfortable setting. So, you know, that will be awfully powerful if we can just prove the things that we know can be true, and you know, several of those things will come a long way, and there'll be a vehicle. Otherwise, you know, we're going to continue to see costs rise, and then we're going to end up with only really draconian things like when we had DocFix and sequestration and other types of severe cuts that nobody really likes.
Well, look, I want to thank all three of you, Liz, Adam, Andy, for a frank discussion about both the importance of value-based care, what we really mean by it, and some of the challenges in implementing it, as well as some paths forward that could be bipartisan and could play a really important role in the core issues we've talked about today. We came to some discussion in the last couple of panels around affordability, but in terms of population health, really seems like a valuable discussion for how to make progress in reversing the slide. So thank you for being on point and on a very thoughtful discussion about a challenging topic that's right at the heart of healthcare reform. Thank you all for joining us today.
Thanks.
And we are just about done. I just have a few more thanks to give out. I mean, look, this has been a wide-ranging set of topics today. We mainly were focusing on getting some big ideas out there, like Farzad said, make sure we're asking the right questions and making some progress on answering them. In order to do that, we really appreciate everybody who's joined us here in person and many more online. Those of you who are in person now are just 1 minute away from reception, where we hope you'll join us for something good to eat and drink. But I do want to give a special thanks to all of our conference speakers for a wide range of perspectives on some of the most challenging issues in American healthcare, public health, and affordability, to Bob Margolis and our advisory board at the Duke-Margolis Center, to our sponsors today, Alexandria Real Estate Equities and ADVI, to our collaborators and partners who make our day-to-day work possible. There are many of you here who have come up with the ideas and rolling up sleeves with us to try to make progress. And of course, the entire Duke-Margolis team. I especially want to call out Luke DeRocher, Hannah Vitiello, Patty Green, Morgan Romine for their planning and preparatory work for pulling this all off today. We hope you'll continue to pay attention to what we're doing, follow us online,
participate in our events. And that includes our reception that's starting right now. Thank you all very much for joining us today.